See my slide? I think can, right? Should be okay. So let's start. I know my voice is probably not in the best state now, but I worry that if I don't do the session tonight, then perhaps it's a bit difficult for us to find a. I think there's some echo, right? Yeah. Can you hear me now? See. Okay. So we will start. So tonight, basically, we have total of 6 communication practice lah. Oh? And anyone any issue with echo?
No.
No, right? Can hear clearly lah. Huh? All right, sure. So I will just proceed. Good evening, everyone. I hope those that are going for directory are doing practices constantly and consistently, because I think now it's already almost reaching end of the September, and there are two diets. I mean, there are two batches, right? One is in October and another one is in December. So those in December maybe will not feel the stress yet, but those in October, I think in another 1 month, you all definitely the last 30 days is perhaps the most crucial one. You will need to make sure that you don't waste the time much and do enough revision. Okay, so let's start. So today, we have a total of 6 communication station. So just to recap, since the last that I have the skill station was quite a while. So the practice, there's the new format, the station 1 and station 4 is the one that will start off with communication for 10 minutes, followed by respi and abdo. Okay, so it's recommended that if you try to set yourself a target of 8 minutes when you talk to the patient, and by the time an examiner tell you there's only 2 minutes remaining, I think you should start to address concern. Mm. Okay, so the marking sheet, the new format, you can see that com skill is very important. Like I mentioned, the passing mark is 11 out of 16. So let's say you screw up one comms case already 12. And clinical consultation for long case, sometimes you may not able to score full marks. So that's the reason why, if possible, we really need to aim comms skill to be full marks. Oh? So let's start with the first candidate. I think it's Dr. Cheong. Dr. Cheong, are you there?
Yeah, I'm around. Yeah, can you hear?
Yeah, I can hear you well. Okay, are you ready?
Yeah.
So I'll give you 5 minutes for preparation, and then we will start the timer. Okay?
Okay.
All right. This is your Okay, time's out, Dr. Cheong. This is the patient, Dr. Addison. Please start.
Okay. Dr. Edison. Good morning. I'm Dr. Chung here. I just want to confirm, are you Dr. Edison, 28 years old?
Yeah, I'm 28 years old.
Okay. Hi. Dr. Edison, we are here today to talk about your your issue in the wards. Is it okay for you?
Oh no, what happened, doctor? What are you telling me for? I thought we are at the same level. Do you have to anything in particular you want to tell me?
Dr. Edison, I hope you to calm down first. It's just a casual moment that between you and me. As I just want to talk about your issue for these days, because sorry to hear that. I hear some complaints from our colleagues. So I just want what clarify with you what has happened actually.
Yeah, doctor, what has happened?
Um, Edison, just how long you been in rheumatology ward?
Yeah, I joined slightly later than you. It's about almost 1 month now.
Almost one. How do you feel for the past 1 month?
Yeah, I've been having a lot of issue recently lah. I know I'm not being punctured. That's why probably that's the reason you want to talk to me.
Mm, are you okay if you want me to talk further? Edison,
Yeah, sure. I'm okay.
may I know what have you been experiencing this 1 month? What stress that are you ongoing? Can you share with me?
Sorry, what was your question?
Can you share with me what stress are you experienced this 1 month?
Oh, doctor, yeah, Chong, I have a lot of issue, a lot of stress going on recently. My I'm preparing for my MRCP PACES, which is going to be in dietary in the next 2 months. and
Mm-hmm.
because that was my initial plan. If I manage to pass the exam, I can migrate to Canada. I can be with my fiance. But unfortunately, last month my fiance I just found out that she had an affair. I was so angry and so sad, and I decided to leave her. And now I'm staying in the hotel, in the hospital hostel. I'm staying alone, and I really feel very burnt out with all the everything that happened to me. That's why I started to drink alcohol because I feel alcohol is very good, lah. Once I get drunk, I don't remember anything. It seems like it can numb my feelings.
I'm so sorry to hear that, Edison. I I can't understand how much you has been experienced this 1 month. It must be very distress for you.
Yeah, it's very very sad, doctor.
Um, I'm sorry to tell you that actually our staff can smell that alcohol smell from your body. So
Oh,
that's why they has been complaining about this to me. Um, Edison, I can't understand how much you undergo this 1 month. However, because we are working as a doctor and we are facing our duty is be professional to the patients. So priority also patients. So it's not good that you drink
mm.
alcohol then you came to work.
Yeah, I know, but what I feel better. I don't know. That's the only way, to me to cope with the situation. Mhm.
Edison, do you need help? Need help to do you need to take some days leave or off so that you can get away from the works that then you can relax your mind?
Yeah, I think that's also possibility if I can, but I didn't tell anyone about that. I don't want to burden everyone. You see.
I will keep this as a confidential. I wouldn't tell anyone about this. However, as a colleague, I hope that um, you you might succeed to get the target in the passing the exam in the paces. However, for the past 1 month, if you continue behave as the past 1 month, um, your efforts that you spent previously has I would think that it's not worth already. You might not even ready for the exam.
Mm.
So I think maybe you should take some days leave. That
Yeah, doctor, it's okay.
yeah.
If it's just because of alcohol, I can just stop drinking the alcohol. It's okay.
Mm.
There's no other issue, right? I mean, just alcohol issue, right? I can always stop alcohol.
Apart from that, there's a few complaints about your attitude.
Oh no,
That
more complaints, doctor. What else? What else you want from
yeah.
me, doctor? What kind of complaint?
Mm, I just want to clarify to you there's one patient that actually said that you are a bit inappropriate because you're walking casual attire in the ward. So that's why that yeah, and also you late for the ward rounds lah. So
Dr. Chong, what right you have to speak with me like this? This is none of your business. This is my own business. I can choose what to wear in the ward.
yes, definitely. However, because we are professional, definitely usually we wear um, um, not a casual suit lah in the during the working hours. Um, I'm not at the place that actually I can talk to you this. However, as a colleague, this is what I respect you. That's why I told you this issue.
Oh, okay, okay. I respect you as well. I will try to do about it. No, I will try to wear proper attire.
Mm.
That all you
Another
want?
thing, another thing is, um, sorry to say that our nurse saying that you a bit rude to them. I just want to clarify what has happened actually.
Yeah, I recently become very irritable, like especially when I got hangover and then I was late to the ward. They keep ordering me around to do this and that, take bloods, order the lab. I feel very, very irritating. Sometimes I shouted at them lah. And then at one time, I think last week, one of the student nurse actually, I think she cried lah. But I don't care.
Lisa, I can see that you're very distressed because several things is happenings in your life, and this is a very distressing issue.
Mm.
However, as a colleague, I very concerned about your attitude. Your attitude was not like that before this. So, do you think that you need help from any psychiatrist or a psychologist on
Mm.
this?
But once I sick into that path, people will think that I'm mad. I don't know, Dr. Chong. I feel like if I go for that pathway, then everyone will just label me as a PSY. I feel very inferior of that. 2 minutes left.
I can see I understand your concern. However, Edison, um, being seeking help from a professional teams, and there's no wrong for that. And I believe there are professional way that actually can help you in settling your issue.
Mm. I will consider about that.
Okay, great. I hope that you can consider about that. And if you're ready, I can write the refer letter to them so that they can see you as soon as possible. Anything else, Edison, you want to tell me more on your
Yeah, Dr.
problems?
Chong, you won't
Mm.
tell our consultant, right? What will
Um,
happen?
regarding this, I have no rights to tell consultant at all. So I hope that you the complaints from the our nursing staff and won't reach to him also lah, because yeah, I wouldn't tell him because I will keep this as a confidentiality between you and me. I hope that if you if you do have small problems, any issue, you can always just look for me. I will see that what can I help you.
Okay, okay. Nice to hear that, Dr. Chong. You're very kind.
Edison, we remember we are healthcare worker trained, and we need to be professional in towards our patients and also our beloved nursing staff. So any colleagues that
Thank you, Dr. Chong. Time's up.
yeah, yeah, thank you.
Okay, time's up.
Mm.
Okay. Okay. How do you feel about this scenario?
Actually, this scenario I flipped through, then I just skip last time. So
You oh,
I
you encountered this scenario before?
no, I mean I saw the riders and then I just skip it. I thought it wouldn't come out in exam.
Yeah, I mean,
Uh,
to me,
uh,
when they jumpstart the whole com skill in a new
uh,
format, right? There's always a possibility that all the old format kind of scenario can also recycle back again. So that's the reason
I
why
see.
tonight is
Yeah,
quite important for us to go through those, less commonly practiced scenario, especially this one. What
yeah,
if you're going to tell what is the theme of this communication, what is the theme?
yes, correct. Yeah, but I never really do this because it's not towards the patients and also relatives. It's
Hmm.
towards colleagues. It sounds like
What kind of
more
theme is this scenario, do you think?
um, confidentiality.
No, no, no. I mean,
No,
not
sorry.
ethical or legal issue, but more of the theme of the scenario. So we got a lot of theme like explain a disease. We got
Mm,
theme like explain complication, explain or even breaking bad news, or genetic testing confidentiality, like you say. How about this kind of scenario?
um, I'm not sure.
So it's
Not
called the
sorry.
doctors in difficulty, DID.
Oh, the ID. Oh, okay, okay.
So actually in NHS there's a proper guideline on doctor in difficulty lah. Definitely not in Malaysia, not that we know
Mm,
of lah. But
mm,
but in UK there is this doctor in difficulty kind of pathway when a doctor's having issues, and it's quite common that colleague of an equal level or not if not maybe like higher level, we'll talk to the colleague in difficulty and we'll activate this kind of pathway. So
mm,
in order to know what kind of pathway, we need to know a bit of the background knowledge. Or
mm,
else you will feel like it's a bit difficult to direct the conversation because there's like a lot of issues you hear
mm,
from the nursing side, from the patient, you know, and also you try to explore what is his issue, and
mm,
you I think you did well in the sense of you try to ask him actually what happened, what has made him change to begin with.
mm,
But generally, that is a approach that you should follow because once you know that
mm,
approach, you will know that
mm,
actually the informing the consultant part is something that's unavoidable.
mm,
You cannot say that it's confidential, therefore I will not inform my consultant, our consultant. No, according to what this doctor in difficulty approach is, informing consultant is part of the thing that you should mention to the patient, not the
mm.
patient, sorry, to the colleague.
I see. Mm,
So there's this approach called SPICE approach. Let's go through
mm.
together.
Okay.
So SPICE approach, there's a few things. S mean it is a seek information. So you want to seek information regarding what has happened. You try to mention a few issue that's what you hear lah.
Mm,
And you want to know what is actual issue from the colleague. Okay. And I
mm,
found out that actually to kind of like open up the sentence in the discussion for this scenario is difficult. So it's always important for you to prepare maybe just the opening sentence. Lah. So you also feel difficult, right? Just now when I try to be, try to be angry with you. Oh, why you suddenly want to speak to me? So
mm,
it's important for you to kind of like prepare how do you speak when in a very gentle approach. You can mention
mm,
that introduce yourself. I need to speak to you about certain concern that was been raised by some of the staff in the ward.
mm,
And we all are very genuinely worried about you for the last few weeks as your
mm,
behavior seems to have changed. Is it okay with you? Perhaps if you
mm,
start with this kind of approach,
mm,
first you show concern and you show
mm,
care. Say we all are worried. We want to know what happened to you as you already changed. Uh, do you want to talk about it? Perhaps I think that's a better way to to talk about the agenda. And then the
mm,
first is the S, which is the seek information, in which you have raised out issues and also the actual issue. Yes, you also did it in a different way, but I think it's acceptable. What has
mm,
that was troubling you, or actually you have issue with recently? Second thing is actually you must always focusing on this key, which is the patient safety.
mm,
So part of the SPICE approach always need to highlight the fact that patient safety is still our main priority, regardless of what has happened to our personal life. Unfortunately, we still need to make sure that our patient is safe and they are being
mm.
treated respectively as well. Okay,
Yes.
so that
Mm,
is our main priority. So you must highlight the fact. And the third, which is the I, is the initiative, lah, no?
mm,
And make him realize that his personal life has now affected his work behavior and what are the things that can be improved. Okay, so you must make him realize that, oh, actually, from what you have told me and from what the nurse have told me, it seems like your behaviors. Unfortunately, I'm sorry to tell you that it seems like already affected the patient's safety and care, and therefore
mm,
it's important for us to see how we go about it. How do you think about this? So always check back with the patient, check back with the colleague, what he
mm.
think about it. Okay, and then the second last is the E, which is the escalation to the consultant or the supervisor.
Okay.
So yes, if the colleague asks you whether you want to whether you can avoid being informed to the consultant, you can say unfortunately, consultant will always need to aware of your current situation and what has happened. I feel it's better. It will be better if it coming from you instead of hearing it from anyone else, including you. So that's why it's
Mm,
important for you to mention that. Definitely, the
okay.
voices will reach the consultant. You cannot stop this from happening. Unfortunately, I think it is always better if it's coming from you, I think. And it can be done in total privacy. I can always, talk to our consultant and we will arrange a time for you. You can speak to the consultant. I think the consultant may able to help you even more than me. You can
Mm,
stress on that fact. And the
okay.
last, perhaps S, is actually the support and summary, in which you also did. You talk about temporary leave, okay, which is
Mm,
good. Basically, may benefit for some off work time. But I think in this kind of scenario, perhaps it's not a good way to mention straight away about psychiatry. No? because
Okay.
actually a lot of colleagues in this kind of scenario will shy away from psychiatry because of the stigma. So perhaps
Mm,
a better way is you can always refer the colleague to the counselor first,
okay.
because actually the this colleague is actually not really suicidal, may
Mm,
be depressed, but may have some alcohol use disorder, but it looks like quite just a 1 month issue, right?
mm,
So not really like something that psychiatry need to be done immediately. But I think to address his root issue is still the social part, in which I think the counselor will actually help more. So perhaps you can say that I can refer you to the counselor, and then if it's required, then perhaps they will actually seek advice from the mental health as well. And I can also engage you with the occupational health to see how you modify about the work. And perhaps if it's not doable, you can actually uh, take some leave off. And there's also some self-help group as well. This is all based on UK lah, very idealistic. I know in Malaysia we don't really have much of this issue lah. So in fact in UK, part of the pathway, actually there's something called NCAS lah. So it's like an advisory role for National Clinical Assessment Service to actually assess whether a colleague is actually safe to still continue to practice in terms of the not compromising the patient safety. At the same time, what can they do to help? So this council advisory council can actually give or grant some leaves, or actually make the patient colleague actually go away from work for a while and then only come back. So I think this is something that's higher level beyond our discussion. But you can always mention that I think our escalation is more to consultant, and if it's required, I think consultant will do the necessary and see whether anything that at the hospital level we can try to help you, instead of instead of threatening him that he cannot work, things like that lah. I think that's easier way for us in our local setting. Okay.
okay. Okay.
Mm. Okay. So basically,
Okay.
this is the approach lah. Huh? I think you cover actually using your approach not wrong. I would say you cover most of the thing. Just perhaps the
Mm,
consultant part and also the patient safety that you didn't highlight more lah. No?
okay. Okay.
Okay. All right.
Wonderful.
You have any
Thank
comment?
you. Uh, okay. And no, no comment. Yeah.
Yeah, perhaps yeah, it's a quite a shocking scenario, right? Even if I got this scenario in my exam also, I will be shocked. That's why it's
Yeah.
important that you must have some form of approach. So regardless what
Sure.
kind of scenario, you will feel calm and you will just know what are other things to to discuss. Okay.
Yeah. Sure.
So yeah, I think the next candidate, let me see.
Okay.
The
Thank
next
you.
thank you, Chong. Okay, next candidate will be Jonathan. Can you unmute yourself,
Yep.
Jonathan?
Hi, I'm there.
Hi,
Yep.
Jonathan.
Can you hear me?
Yeah, I can hear you well. Nice to meet you. Are
Okay.
you ready for the second scenario?
Yeah, sure.
Okay, sure. So I'm going to start the timer for 5 minutes. Then after the 5 minutes, we will go through the scenario. Okay.
Okay.
All right. Your time start now. Okay, time's out, Jonathan. So this is the surrogate Dr. Stephanie. Please start.
Hi, good evening, Dr. Stephanie. I'm Dr. Jonathan, the onco doctor in the medical. May I confirm if you are Stephanie, 26 years old?
Yeah, yeah, I'm Stephanie, doctor.
Yeah, hi Stephanie. Um, I was just informed regarding the situation that you had a needle prick injury. Um, how are you feeling right now?
Yeah, I'm very upset. Very big check already, very, very, very frustrated. I don't know what happened to me. Really, I will get HIV.
I see. Um, yeah, actually, first thing first, have you managed the wound appropriately? As in, have you cleaned the wound
Mm.
after the needle stick injury?
Yeah, yeah, yeah. I clean it. So what happened is,
Hmm.
after I took the blood from the patient, and then accidentally I was wearing glove lah. I was very cautious. I'm wearing glove.
Mm,
Then I took the blood, and suddenly the hand moved. And the needle that already injected, I mean already into the patient's skin, suddenly got withdrawn out, and then accidentally inject into uh the distal part of my arm lah. So I was very, very worried. Immediately I go
mm,
and wash it under the running water.
I see. I see. Have you informed anyone about the situation? Have you reported to the staff nurses or the sister on call in the ward?
Yeah, yeah, yeah. I immediately informed to the sister on call. So that's why the sister on call asked me to speak to you.
I see. I see. This must be very distressing for you. I believe this must be your first time having this. Um, okay. Actually, you don't have to panic. Try to get to the. We'll try to help you out. Is it okay?
Yeah, yeah. How to help me, doctor?
Mm. So first, may I know the needle that you took from the patient? The syringe was filled with blood. That
Yeah, yeah. It's already halfway filled with the blood. I'm taking the FBC, RP, and RFT.
I see. Okay. Um, for this, we'll try to get to the bottom of this. I think the first thing we need to do will be to inform number one to the sister in charge of the ward, the sister on call, and also we would need to report this to the occupational health doctor, as well as the ID physician as well. Yeah.
Mm.
What do you think about it? Is it okay?
Yeah, yeah. Okay, okay. Sure.
Mm, yeah. And also, since you have cleaned the wound already, is the wound still bleeding?
No, no, no.
No bleeding. Okay. After informing to the occupational safety and health, and also the ID physician, the we might start you on an antiretroviral therapy as this
Okay.
patient sorry, as this patient as you know has is a known HIV. So we will start you on antiretroviral therapy. Are you okay with it?
You mean when? Because you say that you're going to inform and you're going to let the ID consultant know about this. Only you will start, right? But now it's night time.
Mm, yes. Actually, we can start this within 72 hours of exposure. Yeah. So at the moment we can actually start you this antiretroviral therapy, and also then only we can inform them the next thing in the morning.
You
Yeah.
mean you're going to start me like tonight? I need to eat the medication tonight.
At the moment we actually. Actually, I'm so sorry. Actually, we will first inform the ID physician on call, and then after that, we will most likely start the medication tonight
Okay.
after getting the input from the ID physician. Yeah.
How long I need to take this kind of medication?
This medication we will need to take at least for 3 months, and then after that, we will check your status, HIV status also in 6 weeks time. Yeah, to see if you have contracted the disease or not. Yeah. And
That
also
means
we
that
will
now I don't need to check for my status now.
we would we'll definitely check your status now. But sometimes the we will check the status now, and then after that, 6 weeks later, we'll check your status again. Because in the event that in the unfortunate event that if you contracted the disease, sometimes it might not show in the first 6 weeks. So 6 weeks later, again, we will check again your status, HIV status. Yeah,
Oh, okay.
and before this, we will definitely count, refer you to a session of counseling regarding this HIV testing as well.
Oh, okay. Then
Mhm.
do I need to take any precaution?
Mm, at this time, when we are yet to confirm we're yet to confirm your status, your HIV status. As of now, you need to take uh, precaution as well, like wearing gloves, and yeah, wearing gloves as well.
Oh, I can still continue to work, right? No, not an issue, right?
Yes, actually, you can continue to work. This not an issue.
Yeah, doctor, I'm actually also a regular blood donor lah. Can I donate my blood because it's almost 3 months already. I think it's almost a time.
Mhm. Until I see, yeah, until we get the HIV status, I think we should avoid this blood transfusion. Yeah, because there is a chance if the unfortunate event that you contracted the disease, there's a chance that this might pass on to the uh, through the blood transfusion. So it will be wise if we avoid blood transfusion at the moment until we are clear of your infection.
Okay, okay.
Mm, yeah. Um, I, is there any other concern regarding this antiretroviral viral therapy?
Yeah, I mean, any side effect that I need to know of? What kind of medication you are giving me?
We will start you. I'll need to check back on the latest antiretroviral therapy, but we make sure usually we start on 3 medication. Yeah. The side effects generally will be sometimes the usual side like nausea, vomiting. Before that, before starting this therapy, we also check your blood as well, your renal profile, your liver function test, to assess the baseline and some the and we will follow you up from time to time to make sure that the side effect to make
2 minutes
sure
left.
so, yeah, to make sure that the side effects uh, are in control. The side effects can be sometimes can affect the kidney and sometimes can also affect the cause some liver injury.
Yeah, doctor, I'm also staying with my parents as well as my husband.
Mhm.
So is it okay if you don't tell them about this?
Yes, this will definitely be confidential. Uh, However, probably you need to tell this to your husband, uh, but it will
You
be
mean
kept
you want to
confidential.
tell to my husband?
Probably this will be
Sorry?
better. Yeah, it will be better if you can disclose this to your husband. But if you or your parents, if you need any help in disclosing this issue to them, we can definitely be there to help you disclose this issue if you want to. But it will definitely be kept confidential until you choose to disclose it.
Hmm. Doctor, I'm actually planning with my husband to have a kid lah. So can I still have sex with my husband?
At this moment, I think probably we will have to have protected intercourse by using barrier methods such as condom, because this is to prevent any chance of your husband getting the infection. Yeah. Uh, but again, after we check your HIV status, if you're clear, then you can continue to plan for the child. Yeah.
Okay, okay.
Mm. Any other concern, Dr. Stephanie?
Yeah, I think no more. I understand. I'm willing to
Okay.
start the medication.
Okay, fine. Thank you very much, Dr. Stephanie. Uh, okay.
You cannot link. Okay, 3 more seconds. Okay, time's up. But you cannot leave the conversation just hanging like that. You
Yeah.
have to
Oh my God. Yeah.
you have to do a very quick closing lah. I will
Okay.
offer a leaflet brochure website on this antiretroviral therapy as a post-exposure prophylaxis, and you may also I will give you the contact number appropriate to the occupational health. If any issue, you can contact them straight. Okay, so you
Yeah.
must end your must end your discussion. Like, cannot Oh, okay. Then wait the times to come up. Cannot now. So how do you feel about this scenario, Dr. Jonathan?
Actually, I need to really read out on the post-exposure prophylaxis. I've not really gone through the guidelines, so
Mm.
a lot of things. Yeah, it's very to me this is quite hard because I don't. It's a very common. I think it's a very common station, but yeah, I need to read up on the guidelines.
Sometimes com skills is not just about talking, because a lot of times we need to have a bit of background knowledge, or else it's very difficult for us to counsel, because when they ask a more detailed question, we have trouble to answer. But I think you generated quite well actually. Just some in terms of the duration to repeat the test, and perhaps there's something that you can improve further lah. Huh? Actually, in this kind of station, if you have time, like if you have time, it's not compulsory. There's always a hidden agenda. The hidden agenda is such a way that you know that the patient has a HIV, but you cannot exclude that patient may have a Hep B and Hep C as well. So other than just testing for HIV, you are going to tell the patient, the house officer, that we will need to take the hepatitis B and as well as C, because they can be, if Hep C is positive, then it can be treated with direct acting antiviral. If Hep B is detected, unfortunately no treatment, but you can still control and prevent the progression of the disease, right?
Mm,
So it's still important for us to counsel about that. So all this kind of this like counsel, I mean, unless the scenario is specifically mention you to counsel for HIV testing, then perhaps, like for example, the common scenario is someone did a scope and then noted got esophageal candidiasis, and your task is to counsel of HIV testing. For that kind of scenario, you don't need to talk about Hep B, Hep C, this kind of thing. But for needle stick incident
mm,
or even blood contact, there's always if possible, want to talk about Hep B and Hep C screening as well lah. This is just something additional but not compulsory. Okay. So I will go through the approach. Sorry. So to start with this scenario, right? This is one of the scenario that will give exclusion in which you can take history. Okay. This kind of scenario you can take history, but the history is just regarding the needle stick injury. Huh? Because to know how to manage the needle stick injury, you need to know some details on the needle stick injury. So this is kind of the exclusion kind of scenario that we know that com skill you cannot take history other than social history. Okay. But this kind of scenario is the one that you need to take history, and you need to take a very focused history on the needle stick incident. So a better way is actually, what do you know about your health condition, and then what has happened, and then you must explore. I mean, yes, you give some time to explore the emotion, which is good. Pause for a while and ask her how do you feel about it. Yeah, she will tell you she feel picture, she feel angry, she feel sad. Then you proceed to actually discuss that what is the event that leading to exposure. So you must ask her what, because you actually didn't ask about that. You ask the first question you ask is actually, do you wash your hand with the running water? I remember that was the first question that you asked. But actually, to actually get a better opening is actually to ask, what are you doing at that point of time? How did it occur? And then what was done? And then she will start to tell you everything lah. Because if she is a trained surrogate, there's certain thing that she need to make sure that she actually convey to you. So it's all fair for all the candidate. So she will tell you all the thing, and you need to make sure that she clean the wound and then run with the water. Okay, correct. And then and then you also have to ask whether there's any blood coming out from the needle. But yes, you ask whether the syringe inside got blood, which is literally almost the same thing lah. Oh. And then must allow the breathing side to actually stop spontaneously instead of squeezing, rubbing, or even sucking the wound. Okay, all right. I think I think your screen is on. We're going to turn off now. Okay. All right. So after you explore regarding the exposure incident, then you have to ask about. Then you have to inform that this is actually yes, you are very good actually, even though you never really go through this kind of scenario, but you know what to do. Because by experience, we know that we need to inform occupational health service or even the ID consultant or the ED for further risk assessment. Like, but you need to talk about incident reporting. So every needle stick
Mm.
injury is a form of incident reporting. Okay. And this is to prevent, not to find fault or anything, but to prevent things from happening in future. At the same time, you also, let's say the patient is not known to have HIV, but has some high risk behavior. And we'll talk about high risk behavior later. If patient not mentioned like HIV status or not known to be HIV, then you must make sure that you will tell her that I will take an informed consent for the patient later to for the test on HIV as well as hepatitis B and C as well. Okay, if not in this kind of scenario, no need to mention because patient is already known HIV. Then after you talk about incident reporting, you must, if possible, you must explore them whether patient have any checkout before. Since this kind of healthcare worker, they usually will have some recruitment kind of screening, right? Like us, before becoming husband or medical officer, we usually need to screen again. So you must ask her that, have you done any tests on HIV before this while you are working? Then you must make sure the status is actually negative. And that's the important point, that why you want to check the hepatitis B and C at this point of time, which is day zero, which is now. Because in UK, not in Malaysia, Malaysia we don't have this policy, but in UK we got something called IIDB. So if a healthcare worker or any occupational worker suffer for any injury at workplace, then they are entitled for this industrial injury disablement benefit. Okay, so it's important, especially in UK lah. If you're taking the exam in UK, you must mention it. If you're taking exam in Malaysia, probably not so important to mention this full name, but just mention that it's good for us to know that whether you are previously contacted with the HIV before or not. Okay, and generally every hospital have different policy lah. But generally we don't repeat the HIV testing so frequent lah. We don't repeat at 6 weeks. We usually repeat at 3 months because the I mean, this is all to prevent the false positivity, or the serial conversion, or. So the ideal is actually 3 months. Some hospital have 1 month or even earlier, like I say 6 months, 6 weeks, sorry. But generally, I think 3 months will be a more approachable and safer cut off because it's mentioned in nice guideline. And if she asks you why 3 months, why cannot be earlier, then you will say that it can be false negative, and that's why it need to be assessed. Okay. So next thing is you must explain your task is to explain the antiretroviral therapy. Okay, so it's indicated for all high-risk patient if it's not known to be HIV. So those include MSM, sexual worker, IVDU, or actually have some exposure with the HIV, HIV friends, although the patient not known to be HIV or is unknown. So all these are considered as high risk. And in Malaysia, the drug regime that we give is actually Temvir, EM, and also DTG lah. No? Usually we give DTG. Not many centers have RIL, rather cover, but DTG is something that we have. Okay, so usually we give Temvir, EM, and DTG for only 1 month, which is 28 days only, not 3 months that you mentioned. So the post-exposure prophylaxis is only for 1 month. Okay, not more than that. So and the timing is actually to start as early as possible because the patient fulfill the high risk contact. Therefore, it's always, yes, you can say that I will inform with the ID consultant or ID specialist on call. But the idea is we will need to start the medication as early as possible because we know that the cutoff is 72 hours, yes, but the benefit is best seen actually within the first 24 hours, up to 72 hours, extra prorated. So we know that there's no rule to actually give PEP after 72 hours. But within 72 hours, yes, you can give. And ideally within 24 hours. So we need to push for this 24 hours thing. Huh? So you must mention that we will need to start as early as possible. And automatically you should mention the side effect as well as the benefit. You should mention that yes, generally you may experience some mild symptom. Generally, it's not very severe. You can have, you feel want to vomit, you're feeling sick, or you may actually have some loose stool, but generally it's usually mild. However, to start this medication at this point of time is actually more beneficial than harm. Okay, if patient somehow tell you that she's pregnant, then don't worry, the medication can be continued. It's safe in pregnancy, but definitely not in this scenario, lah. Huh? This scenario is such a way that the patient, I mean the house officer still planning for that, but not yet. And automatically, other than explaining about post-exposure prophylaxis, you need to spend some time to talk about precaution as well as social history. Okay, because it's very important. So precaution is mainly you must mention that you must practice a standard infection control measure, avoid and careful handling of the sharps, avoid using any sharp object like razor or any needle. And if you are having any intimate relationship at this point of time, you can still practice, but you need to like what you say is protected sex, and you should avoid any form of blood donation. Okay, and we will also refer you in detail of everything that you need to know to the occupational health department. That's all. You may not have all the time to talk about that in within 10 minutes, so you may want to cut short it and just refer to the occupational health and social support. If you got time, you can mention. And the next important thing is the vaccine. Generally, I think for the new syllabus, you may not have time to ask about that, lah. Huh? But generally, if you have time and you ask about, have you received any Hep B vaccination before? Then if let's say the patient yes have received already, then we'll say we will also check your title. If your title is low, then we will give the booster as well as the IG. And if let's say it's unvaccinated, you have to get the full vaccine. Huh? Okay, that's general. The title that we use is actually 10. Huh? Hep C, basically nothing much. No need PEP. If it's positive, then we will treat you and we will confirm the blood test first. If the patient asks, all this is not important in detail. But let's say if the health, if the surrogate asks you, then you have to address the concern. You have to tell them as well. And the next thing is the concern. So yeah, I mean you have explored all the concern. I think quite okay, correctly. And the last thing is to summarize. This is kind of a scenario that you want to stress on the fact that everything we discuss is confidential. So perhaps you want to mention that when you talk about under the agenda. This our discussion is going to be confidential, but you also stress on that at the end of the session. You say that definitely what have we go through is something very confidential to you, very personal. We will not disclose to anyone. However, if the result turn out to be positive later, I will advise you to inform your family members because they are your main support if you are unwell. And I will offer leaflet brochures website on things about what you need to know about post-exposure prophylaxis and the hospital contact or the clinic contact if any issue. That will be it. So it's a very heavy kind of scenario. But actually, if you practice enough, you will realize that actually, if you go through the flow, you will realize that actually all these are quite fast one. It's not something that very heavy. But if you didn't practice enough, you realize that you feel a lot of resistance, no? When you try to answer the question at the same time, try to give a good answer, and also try to think of what are the things that you want to ask next. Okay, that will be it. But generally, I think you do quite well. Okay, any
I want
question?
to ask, if so when they say as early as possible, like so he was on call, so we straight away start that night lah. Like she
Yeah.
asked me.
Ideally, yes. I mean, for this kind of scenario, it's already confirmed to be high risk.
Mm.
Definitely, for courtesy, you can still say you want to inform my superior, my on-call specialist. But if necessary, we will need to start the medication like tonight, immediately.
Okay.
The idea is to show that you want to start this without delay. That's the only idea.
Then the legal implication if partner is positive. So we, if let's say she becomes positive, we don't have an obligation to tell the partner, right? Like she will have to disclose herself.
Yeah. I mean, we always advise patient himself or herself to tell the family members. The legal implication is something that we won't talk about at all, if possible. It's something that we advise them if they're very resistant to tell the family members or even the husband. Then perhaps something that you need to mention about this is, unfortunately, that's also you have to also consider about legal implication. He have his right to know about your condition so that he won't get the same condition, because this is actually treatable and preventable if it's not in the early stage. So that's why it's important. And there's potentially if your husband are unhappy, there is also some legal implication involved, but you don't need to go in too detail about that because generally is not the main focus of the discussion.
Oh, okay.
Okay,
Thank you.
all right. Thank you. So anyone got any other question? If not, we will proceed with third scenario with Benjamin. Yeah, I can see some question. Let me see here. Regarding HIV scenario, should we explore the HIV viral load or compliance before considering? Yeah. So in this kind of scenario, it's not important for us to know. If you ask, we generally don't wait. I mean, the guideline generally don't wait. We will never wait for the viral load to come out before we give the PEP lah, huh? So PEP is something you cannot wait. That's why it's called post-exposure prophylaxis. Okay, and that's why the cut-off point of 72 hours. We don't wait for the viral load. And if you don't wait for the viral load, there's no role for us to ask in this scenario as well. So you don't have to ask about do we know about the viral load on this patient? You don't have to ask that. It is unnecessary. Unless the scenario specifically mentioned that the viral load was undetectable. That is a bit different. That is get a bit fishy. So you have to see what are the scenario tasks that ask you to do. Let's say the scenario task didn't mention to you that you must counsel on PEP, then you need to think that whether this patient still consider this needle stick still considered as high risk, because we know that not all needle stick need to give the PEP, right? Not all PEP is I mean not all needle stick is high risk as well. So if the patient actually is undetectable, we know that it's undetectable, it's no longer considered as high risk anymore, and therefore doesn't require PEP. And therefore, it's important for us to look at the scenario. If the scenario is not mentioned, then you don't need to ask, because it's not going to change the management. You will still need to give the PEP in view of the patient high risk group. Okay, so next patient pula. I'm the patient, I think. Next candidate will be Benjamin. Are you there? Yeah, can you unmute yourself, Benjamin? I hope you are there. Oh no, I think he left. Hmm. Wait, let me see. Benjamin, are you there? I think not. Never mind. What we do is we're going to move forward first while I text Benjamin. We'll move forward with Yasmin. Yasmin, are you there?
Hi, Junmin. I'm
Hi,
here.
Yasmin. So you are ready, yeah, for the next scenario?
Yep. Oh, I think Benjamin is there. Oh, okay,
Oh,
okay.
is it?
I see.
Never mind, it's okay. We can continue with
Okay.
you first, then we will resume back
Okay,
with
sure.
Benjamin. Okay.
Sure.
Another thing is that I noticed you posted a question, right?
Yeah.
Can he still continue or to operate if he have a needle stick? So very, very good question that we don't have an answer. Okay. Different guideline got different answer. Ideally, we should not operate. But there's also guideline, the latest guidelines say that if a healthcare worker is on PEP, there's no risk of transmission of the virus, even if it's positive. So therefore, it's not absolutely wrong for the surgeon to continue to operate. So who should give the decision? So no need to for us to give decision. We are just like MO becoming PACA, right? We don't need to make that decision. So you just tell that
Ha.
it's a very tricky question. I mean, you don't have to mention tricky. You just mention that this is a very valid question. I can understand that it's very important as well. However, I'm afraid that I'm unable to give you the answer at this point of time. I think we will need to let the occupational health department to assess and they will decide for you. I think that will be a safer way. You don't have to commit if
Yep.
you're not sure. Okay.
Mm-hmm.
Okay,
Okay.
so we will give you the this is the third scenario, right? I think. So
Mm-hmm.
you're ready, right?
Yep.
Okay, so 5 minutes. Start now. Okay, 5 minutes up. Okay, Dr.
Okay.
Yasmin, this is the Madam Salima. You can start now.
Hello, Madam Salima. I'm Dr. Yasmin, doctor in the ward. May I confirm your age? 35 years old?
Yeah, yeah, I'm Salima, 35.
All right. Okay. How are you doing, Madam Salima?
Yeah, good, good. I feel a lot better, lah, doctor.
Okay, that's good to hear. So, may I heard that you've been treated so far for past 7 days. Can I know what do you understand so far about your condition?
Yeah, definitely, doctor. I want to speak to you because, you
Mm.
know, 7 days has been torturing for me. I come here because I got infection in my brain. I was told that I was started on the
Mm-hmm.
medication through the blood channel, and I already feel a lot better. I'm already moving around in the ward. I don't need physiotherapy to teach me how to walk. I'm very good, and I can even smoke in the ward.
All right. Okay. So, okay, that's good that you know so far. But did anyone explain to you that you have quite a serious infection, which is called listeria? So you're having currently a condition called meningitis, which is infection of the layer of your brain.
Mm.
So we the blood test that we have done, sorry, sorry, the blood test that we did and showed also from the sample we took from the back of your from the back showed that you have a bug called listeria.
Mm.
So of course you have been responding well. That's very good for us also as our team which is treating you. But however, I would like to tell you, Madam Salima, that you need to continue antibiotics for 3 weeks at least.
Huh? 3 weeks? No, 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 doctor. I want to go back already. Oh.
Ah, I see. May I know why you want to go back?
Yeah, I already first I feel much better already lah. I don't need to stay in the
Mm-hmm.
hospital. It's very boring. And second thing is
Okay.
I feel like I'm like a child. I keep on being bossed by the nurse. I'm very unhappy lah. It don't feel like home to me lah. I feel very noisy, and the nurse is keep on shouting here and there and keep on ordering me around. I don't think I
Okay.
need to stay here lah. It's very torturing.
I can see that it's overwhelming. I think no one wants to stay in ward for 3 weeks because you're stuck in the hospital. I can see you're quite upset with it. But can you, if you just allow me next few minutes, I just want to tell you what is very important for you to stay in the ward and bear with us with the treatment. So actually you have this the infection where we have special treatment protocol that you need to be on antibiotics and you need to be on special care and special monitoring. Your medication need to be given through your blood channel, and because of this special bug we need to keep you isolated in a special room. And if you don't continue the treatment for 3 weeks, we are very worried that you might have other complications that might have from the infection of the layer. It might go into your brain, you might have a pus in the brain, and you might have change in your memory, maybe your change in your behavior, you might get a fit, which is very dangerous, and we are very worried for you actually.
No, doctor, it
So
sounds like you are threatening me or you very scary lah.
oh, Madam Salima, no, I'm not really threatening you, but we are very worried as a team. We're very concerned and we want the best for you actually.
Mm.
So the treatment is really necessary for you as if you discharge and come in later, once all the complications happen, it's going to be very difficult to treat
Mm.
you. Then the
Doctor, but the
treatment will
hospital
be
food is not
longer.
good lah. Cannot eat one.
I see. So the hospital food is bothering you. Okay. If I talk to the dietitian to arrange some special food for you, would it be okay for you?
Wow, what kind of special food then? I mean, is it fair for other
Um,
patients if you do that to me?
aha. Never mind. I think for the best interest of you, I will try to ask my consultant whether we can arrange for a first class ward or what in the hospital to make special preparations for
Mm.
you.
Mm.
Yeah.
Doctor, but the
So
problem is
I
I
would
also got
yes.
I also got two kids in the home. For the past 7 days, my sister has been babysitting them. And I'm actually a single
Mm-hmm.
mother, so I
Mm-hmm.
cannot tahan already. I need to go back. I need to
Mm-hmm.
take care of them, you know.
Oh, I'm so sorry. How old are your kids, Madam Salima?
One of them is just 1 years old, another one is 3 months only.
Oh, besides your sister, who is there at home?
No, my sister is also part time like that because she also had to running some errands sometimes. So I had to find different relative to take care. It's very troublesome, lah.
Okay, I'm so sorry to hear that. May I know, is your spouse around?
No, no, no. We no longer in contact. We divorced already many years.
I see. Is there any other people who can support and take care of your children because the treatment is very important for you? Do you think that you can talk to the relatives
I have I,
to
I have talked to
emphasize?
them. I have talked to them. They really not free lah. I mean, only now is the my sister is the only one that taking care of them. But once that if
Mm-hmm.
she got some issue, then no choice already. I have to go back and take care. There's no one else in the family that can take care, doctor.
I see. I'm so sorry to hear that. Okay. I will try to talk to the social service here to see whether they can have any child support for your children. Would that be okay for you?
Oh, that would be very good, doctor, if you can sort that out.
Okay. All right. Okay, that's good. Another thing, Madam Salima, I want to know how long have you been smoking?
Yeah, this one about 10 years.
I see. Okay. Have you had any plans to quit? Have you thought about it?
No.
Okay, smoking is very hazardous for your health, and also actually, smoking inside the hospital is also dangerous for other patients. So,
Oh.
I hope that you can try to avoid smoking while you're in the hospital. But
Why why
if you're
why I cannot smoke in the hospital, doctor? That's the reason why the
oh,
nurse has been, scolding me lah, which I don't like.
I see. I'm sorry, but I think they were just, quite concerned because in the hospital there are a lot of oxygen ports. So if there's fire, then it might trigger a fire in the hospital.
Oh,
So it will be very dangerous for other patients who are on oxygen. And yeah, um,
okay, okay. Doctor,
I see. May I know? Mm-hmm.
there's no oral options of the medication, I can just eat with oral antibiotic and go back, right?
Um, There are possibilities of oral options, but I will still need to discuss this with my consultant and also the microbiologist. But actually, it's the microbiologist, the doctor who is specialized in all these bugs, which recommended for you to be on 3 weeks treatment. So I
Hmm.
think it will be a longer course if you take tablets. And sorry, Madam Salima, may I know
Minutes left.
how are you financially?
Yeah, financially I'm broken lah, doctor. I not much of money, to take care of
Mm-hmm.
2 kids at the same time. I'm also a single
Okay.
mother. I I do some part-time works lah, the wash
Okay.
dishes and also the
Okay.
MACD, promoter. But all this thing is also bothering me as well. I think the hospital bill is also filling up, and I'm very worried lah. I don't think I can pay already lah.
Okay. If we actually write a sick leave letter when you discharge, would it be okay for your employer to emphasize why you need treatment inpatient? And probably I will talk to the social service also for your financial support for you and your family.
Yeah, yeah, that would be
Mm.
great, doctor.
Mm-hmm. Any other concerns, Medicine Lema? As a team here, we really would like you to stay to continue treatment in the ward.
Hmm.
But at the end of the day, it's your choice, but I would really really emphasize that you stay in the ward and get the treatment for 3 weeks.
Doctor, you can't stop me from discharging myself, right?
Yeah, at the end of the day, it's your choice, but if you feel that you still have some grouses, I can ask my consultant to speak to you, and probably
Sure,
I'll give
sure.
you some brochures and pamphlets about the medication and also your current condition, which is the meningitis.
Mm. So if I want to discharge and then you will give me some medication, the oral one to eat, I'm
Mm-hmm.
okay to come back in the clinic, to see you all. Just that I don't feel like staying, continue to stay like this.
I see. Okay, Madam Salima, I will discuss with my consultant and get back to you if that's the best option for you. Okay?
Okay, okay. Thank you, doctor. Time's up.
All right. Okay.
Oh, very good, oh. I think you did very well. How you think about your performance?
Not good. Actually, I'm not sure. Is there any other alternatives?
Alternative? As in what
Yeah, I mean,
alternative?
because you wrote here in the stem, offer other alternatives if she refused to stay. I mean, is the oral antibiotic an option actually?
Yeah, the question is you don't know, right? Because it's not mentioned in the scenario.
Correct.
So you need to be intelligently address the alternative. Okay. So the
Mm-hmm.
alternative you can mention is you will confirm back with the microbiologist and we will explore whether there's really desperately whether there's any oral options that can actually treat this bug. If possible, if yes, then yes, I can give you the oral medication. But you must stress on the fact of the follow up lah. You must make sure that you
Mm-hmm.
must follow under us in the clinic and we will assess your condition from time to time. Okay, this is the
Mm-hmm.
kind of like thing. So what are the themes in this scenario? What is the theme, the main theme for this scenario?
Um, let me think.
Refusal for admission
Refusal
or
of treatment. Nah.
refusal of treatment? No, 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 she's accepting treatment, right? I mean, she already 7 days stay in hospital. She also agree for oral antibiotic if possible.
Correct.
So this is a scenario of dharma lah. We call it discharge
Oh,
against medical advice. It's a AOR, right? In
okay.
a way.
AOR.
Yeah,
Correct.
it's a scenario AOR, okay?
Yep.
So this is the AOR. So the criteria, I mean, for this scenario, I think you did really well. You explain and you try to explore, you try to negotiate. That's the main issue that the examiner want to see in our candidates. Regardless of how what are the final decision is not important. The important thing is we don't force patient. We try to reassure and try to re-explain again to reinforce the importance of continuation of treatment to prevent the recurrence infection and also the worsening the spreading of the infection. Yes, I think you did that part very well. And you
Mm-hmm.
also explore the alternative, which is possibility of discharging with oral options and see back in the clinic. And you also need to continuously ask the same question. Any other reason that you don't feel
Okay.
like staying in the hospital,
Yeah.
So you can see that how many reasons I given you. Oh,
Yeah. So
a
many
lot of reasons,
reasons.
right? Until
Yes.
at the end I goreng, I don't know what reason already.
Yeah.
Yeah, but this is a very common kind of like a MRCP, very template classic type of scenario that we all need to be familiar lah, huh? So we'll go
Yep.
through. So yes, this is actually a scenario dharma lah, huh? So you must
Mm-hmm.
try to explore that what is the reason that the patient is unhappy. Okay, you must know that what is the reason. Yeah, hospital food not good. Don't like the attitude of the nursing staff. Smoking issue. Yes, in this scenario, the hidden agenda is actually to actually address patient to stop smoking, because it's not it's actually will affect the safety with the rest of the patient as well as herself, and also the all the staff. So in which you did that, which is good. And also to address the social issue that she is actually single mother with 2 children, and
Mm-hmm.
added up another issue of the financial issue lah, which the
Mm-hmm.
hospital bill is piling up, may not able to afford. Yes. So this kind of scenario is very simple. We told everyone social welfare is a key to it. And then
Mm-hmm.
you need to address one by one what are the things that you can do. So the only thing that is not so perfect for your performance is the hospital food part lah. Surprisingly, I didn't expect you to to even when I mentioned about the hospital food, then you say you speak to the dietitian and maybe change the better food, things is better. Yes, that's a possibility, which is not wrong. But subsequently when I
I was
question you
thinking
further,
of first
mm,
class ward actually.
yeah, first level is a bit too much. You cannot do that. It's
Okay,
not
okay.
justice. We need to apply the principle of the all the four ethical principle, right? One of it include
Yep.
justice. We should treat everyone
Mm-hmm.
as equal. Okay, not
Mm-hmm.
not because
Yep.
patient want to AOR, we offer the special treatment or special level
Mm-hmm.
of care, which is not
Mm-hmm.
the main idea lah. So this is like a
Okay.
trap lah. If you mention like you want to offer special class things like that, then examiner may not be very happy to give you full marks. Okay,
Yeah.
so you must mention
Yep.
that it's always possible that I know hospital food sometimes may not feel good to you, may not be delicious. So it's always possible that we will give allowance. We will speak to my consultant. We will give allowance. Probably you can give ask your relative to let you bring some food for you. Will that be okay? And we can also change to other form of diets. We got a few options available. the diet that you're on now may not be suitable. You may not like it. You can try to change with other diets. You know that in Singapore, SGH, Singapore General Hospital, their diet are so fantastic, so awesome. Every day is different one, We're not have same diet. And their food are much more
Okay.
palatable than us lah. Sometimes we on
Mm,
call also we eating the patient food also. So
mm,
yeah. So it's unfortunately is what it is, but you need to mention that the idea is not to give patient privilege, try to convince patient by giving special treatment or privilege. The idea is try to treat everyone as equal
mm.
and try to negotiate with a plan that is not, you won't sounds like you are giving special treatment to them. Okay, that's why it's
Okay.
important. The hospital food looks like a very simple question, but it's a trap question, it's a trick question. Okay,
Okay.
so yes, you mentioned about the Dama risk, which is a worsening infection. Sepsis, you can use blood poisoning in a layman's term,
Mm-hmm.
and
Mm-hmm.
release to the life-threatening situation, including death. Okay, you must mention about this death and risk of recurring infection if the source is not removed or antibiotic duration is not adequate. Yes, you address the autonomy and also the capacity. Patient seems like able to understand, seems like able to have capacity. So that's why you cannot
Mm-hmm.
deny her on the fact of
Mm-hmm.
AOR. So
Mm-hmm.
that's all the alternative part you need to address. You need to make sure that she understand that it's her own responsibility to actually take care of her own health. If she insists on discharge,
Mm-hmm.
it's possible. We will need to let you sign a formal documentation regarding what have we discussed, including what are the issues, the reason, and also the advice. And what you will do, you will contact the microbiologist to discuss the possibility of changing, if it's possible. And you will also
Mm-hmm.
inform the senior colleague, which is good. I think you end your way to actually refer to your consultant and then to discuss further, which is not wrong. Because
Mm-hmm.
the key idea, the alternative option is if you cannot convince her to stay, and perhaps you may not be the best person to convince her, it's always good to
Mm-hmm.
escalate to the higher up, which is a senior colleague or even your consultant. And
Yep.
if let's say she refuse or what, you can also in UK system, there's always a GP that is taking care of patient. But in our setting, we don't have. But let's say is in UK scenario, you can mention that you can also inform your regular visiting doctor so that they are knowing about your condition, so that if any issue you can go back to them, they know about your condition, or you can come back to us, we will have a record. Okay, and then you also must stress on the early clinic follow-up, first available clinic. This is the point you need to show the privilege, which is not wrong.
Okay.
Okay, you need to show that you are trying your best. So this is the fact that I will give you the first available clinic follow-up appointment if you
Mm-hmm.
decide to pursue on this. And I will advise you to visit the emergency department, or I will give you the hospital contact number if I'm well. So this scenario is not so much about giving leaflet, pamphlet, brochure about meningitis. Yes, you can mention that,
Mm-hmm.
but the later part, which is the hospital contact and the emergency and also the follow-up, is a more important thing that you should highlight as well. Huh? I
Yep.
think I think if you encounter the similar scenario in the real exam, I think you will able to get a full mark, because I think your approach is very good. It's just that just a bit of fine tuning. Huh? Okay.
Okay.
Any
Thank you
any
so
question?
much.
No problem.
No. This one for I just wanna ask, the listeria is not like Nigeria. You need to do like contact screening and so on, right?
No need, no need.
Uh.
No need contact screening, and also no need antibiotic prophylaxis for those in contact. Listeria
Uh-huh.
don't need, but Neisseria,
Yep.
yes, yes.
Yep.
Listeria is something that not supposed to grow lah. In the normal
Yep.
people lah. It's an
Yep.
immunocompromised patient, right? So
Mm.
normal people even get listeria also may not have any symptom or any infection at all. So
Mm-hmm.
therefore, it doesn't warrant any special contact tracing lah.
Yep.
Okay. Any other question?
Jermaine, one
Mm,
more. So
mm.
actually, it was just my assumption that they might give a typical classical scenario because it's the new format. You also think like that, is it?
Not really.
I mean,
The RCP,
new
the
format.
RCP they have decided and they have agreed that because they are changing the comp skill from 20 minutes to 10 minutes, they have
Mm-hmm.
agreed that they are not going to change the type of scenario that will come out in exam.
Oh.
And they will not they will not have, they may have some new scenario, but generally like explaining some new disease that is not previously discussed in the past. They may have all this kind of like a bit of one or two station, but generally it goes back to the principle of the types of scenario. So the scenario
Mm-hmm.
can be very different. Let's say it's like some other, some hip fracture and then got infected, periprosthetic joint infection, and then now the patient refuse antibiotic, want to discharge. I mean, the types of
Mm.
scenario can change. They can
Yep.
be very creative. They can be a lot of, I mean, new, so-called new kind of scenario. But the
Yep.
principle of the team is the same. So you
Yep.
must, for us to practice a com skill, we don't practice a particular scenario unless it's like special one. For example, like genetics testing, counsel for transplant or kidney biopsy. Those very specific one, yes. But generally, we go by team. Like this kind of team can apply to, I mean, the approach is the same for all the team now, huh? Just like what we
Mm.
discussed just now, the team to describe about needle stick injury, regardless what kind of scenario, the needle stick injury can still come out, okay?
Yep.
And AOR is something that definitely can come out as well. And therefore, it's
Mm-hmm.
important for tonight's session for me to go through again, because this is like a restarting the RCP com skill station again. So there's always a
Yep.
risk. This is just my thought now. There's always a risk that they will going to repeat back those old scenario again, but in a different way. But regardless how, the team would be almost the same. So that's why it's important for you all to go through. You may go through rider, but to me, sometimes rider some of the management and the answer is already outdated, so may not be very accurate. So you can go through
Mm-hmm.
the rider if you all want, just for the just to know about the scenario, just to know how do you go about it. But generally, if you all have my notes and also my previous the campfire home skill discussion, then if you practice based on that possibility, usually you won't go too far from the real exam scenario lah, because that's how I practice as well. Okay.
Yep.
All right. So next will be Benjamin lah, huh? Benjamin, are you ready?
I'm here. Can you hear me?
Yes, yes, I can hear you. You're ready,
All
yeah?
right, great. Yep.
So you are the fourth candidate. Your time start now. Okay, 5 minutes is up. Dr.
Right.
Benjamin, this is the patient, Mr. Sonic.
Okay. Hi, good evening. My name is Dr. Benjamin. I'm the medical officer here in our neurology clinic. May I confirm if I'm speaking to Mr. Sonic, 45 years old?
Yeah, I'm Sonic 45.
All right. Hi, nice to meet you. Okay. I understand that you've come to see me today because of a few concerns regarding your previous treatment by your general practitioner. Before we start, can I just ask what your understanding is in your own words about what's happened so far?
Yeah, doctor, I'm very unhappy because 2 years ago I have been following up with my GP for headache. Initially, he told me I have just migraine. Then, after recurrent visit, because of the same similar headache, I managed to convince the GP that 9 months ago he finally decided to request a CT scan for me. After I told him that this thing is not migraine and not migraine, and then now the CT scan 9 months ago actually showed there's a lesion, there's something tumor in the front of my brain. And and subsequently I have to underwent a major operation by the brain surgeon. So I'm really unhappy about this GP lah. I want to take a legal action on him.
I see. I'm very sorry to hear that. I understand you must have had a difficult few months over the course of this entire incident. So I'd like to go forward a bit. Hopefully, we can work together and we can discuss a bit about what's happened. Before we go on, can I just ask what specifically are you unhappy with regards to your GP's management?
Yeah, it's the delay in terms of the diagnosis of the brain tumor, doctor.
I see. I see. Okay, now based on the information that I have so far, I understand that your GP has actually requested for a CT scan roughly about 9 months ago, which has been following about a year or so after you initially presented to him with a headache. Is that right?
Mm.
I see. All right. Now, I would like to point out also that your GP has also made a timely referral to our neurosurgical team, which has actually continued to undertake a surgery for you. And can I just ask also what you understand about the outcome of the surgery?
Yeah, I was told by the brain surgeon it's still possible to remove the brain tumor completely.
I see. All right. So I understand. So again, this is already you have already been underwent your surgery about 6 months ago, and based on the information that we've gotten, it was the tumor in your brain has come back as a low-grade benign meningioma. May I ask if you've been told about this
Yeah,
term or what you understand about it?
yeah, I understand that this is just a low level form of cancer lah, which can be cured
Right.
with the surgery.
Okay, yes, that is indeed correct. And so far, what it seems is that this tumor is unlikely to transform into cancer and was unlikely to have been cancer to begin with. More importantly, the tumor has been completely removed by the neurosurgeon, which means that the surgery has been a success. Now, overall, based on the information we've gotten, your GP has been treating you for a headache, but subsequently, based on the fact that your headache has not really responded, he has arranged for a brain imaging, a brain scan, and that has actually been the one to pick up the tumor. So your GP has actually acted in a way that enabled our neurosurgeons to proceed to solve the
Mm.
problem and
I know,
also to
doctor,
remove the tumor.
but the
Mhm.
problem is that why can't my GB send me for investigation earlier 2 years ago? It's still so much
All
of
right.
delay.
I see. All right. I understand that you're upset, and I do appreciate that is entirely reasonable for you to feel so. Can you tell me what you feel that you have wanted your GP to do instead?
I just want some compensation, because I'm very unhappy. If I not bugging him to do a CT scan for me for so many times, then perhaps this thing will never be discovered and my headache will forever be there. It's very disabling for me in my activities.
I see, and I understand that. Now, you've mentioned again, I do appreciate that you're very upset with your GP, and you mentioned that that's the prime reason you like to undertake legal action. But you also use the word compensation. May I ask if there are any other reasons that you would like to pursue legal action?
Yeah, I want some money, because I'm actually not from a wealthy family. I'm also financially tight, you know. And at this point of time, I feel my health is being compromised. That's why, if possible, I want to gain back some money for me to earn for the money for my living.
I see. May I ask if your finances are currently putting pressure in terms of your family, in terms of your work, or in terms of
Yeah,
your daily life?
yeah. I'm married and I'm working as a contractor, and because of this tumor removal of my brain, I have to on sick leave for quite some time. And now that I start to
Mhm.
work back, I cannot do heavy jobs, and therefore my salary is also not as good as before. And I have a wife and two children to to actually support as well.
I see. And thank you for being so forthcoming with me. And I can appreciate that this is a difficult situation for you. Now, for our side, given that we have only been managing you insofar as you've been presenting to our clinic, it would not be fair of any of us to speculate about your GP's care. In terms of right now, I think it's best we stick to facts rather than speculating. What I understand from the situation though is that your GP has also been managing your headache appropriately, in the sense that while he's initially made the diagnosis of a migraine, he did eventually pick up that this was not typical of a migraine, and then scheduled you for a CT scan, which enabled the neurosurgeons to act.
Yeah,
Now it's very
but
right.
that is after I told him the medication is not working. This is not migraine
Mhm.
many times. Only then he finally do a CT scan.
Right, I understand. Now, allow me to just talk a bit through about how we manage headache. A lot of times, a lot of patients come in for headache, and many times there are many causes for the reasons why they have. Sometimes tension headaches, sometimes migraines, for instance, very common causes that sometimes may take time before they're able to show a response to the medications, number one. And number two, sometimes may take a bit of trial and error to find the correct medication for them. Bear in mind, this is for patients with nothing wrong in the brain per se, without, in your case, having a brain tumor. Now, it may very well be that I understand the concern. A lot of people do ask and do request for an urgent CT scan in order to look for the brain. But I like to also point out that this would not be an effective use of resources for all patients to be scanned immediately, because this takes away the ability for patients who really do need the scan to have it timely. For instance, if your GP was to arrange for a CT scan for every single patient with a headache, he may not have been able to schedule you for a CT scan when you eventually didn't need one.
Okay, doctor. But do you
Right.
think he really messed up, right? I mean, the neurology doctor and the nurses also say like that. What do you think?
You said that the neurology doctor and the and the nurses say that. Can you tell me exactly what you mean by that?
Yeah. I mean, I heard them whisper when I was admitted that time. They also say that,
Right.
how the GP also missed, and then how come so long only CT scan was done? I think he messed up. I think they also agree. What do you think?
Okay. Now, first of all, I do want to point out that in general, it is not appropriate for us to
Two
discuss
minutes left.
yeah, thank you. Yeah, it's not appropriate for us to discuss the management of another team in private setting where a patient might be able to hear about it. And I'm sorry to hear that that has also influenced you and caused some distress. But once again, I just like to point out also that your GP, I feel, based on our standards, has acted in accordance with what his resources were available, and has adhered as best as he could to the medical practice that has enabled you to arrive at this current outcome. At the very least, your tumor is removed and your headache has also been treated. So this is something that I feel is positive. Now,
Mm.
if you would like to continue to pursue legal action, this is entirely your right, and you will be referred to an independent committee who will assess whether or not your GP has not been acting in accordance with medical practice. But this is not something that specifically we can either support or go against. From here, we are only able to stick to facts. Are there any other concerns, anything else that you'd like to express?
Yeah. Is it possible for you to prepare a written statement to support my lodge of my complaint against the GP?
All right. Unfortunately, all that we are able to state is that based the facts, like I mentioned, based on what you have been treated under us, we can only stick to the facts of your presentation to a neurology clinic and also your surgery, which has just been done. As to what has occurred in the GP within the confines of this practice, I'm afraid that it is not our role to speculate. We will not be able to do so. But there are a few things that I can do. First of all, I do understand your family is under quite a bit of stress for your finances. We can refer you to social welfare, get them on board and see what they can offer, see what we can help with. We can also give you a few leaflets to refer you
Okay,
to
thank you,
the
Dr.
appropriate
Benjamin. I'm
teams.
Sal.
Yeah, thank you.
Okay, all right. Thank you. How do you feel about the performance?
Oh, tough one. I think this is not an easy scenario because I think based on the information that we had left that I was given here, I couldn't really talk around much about the treatment by the GP, so I chose not to talk about it. I don't know whether that was the right strategy.
Yeah, I think your approach is quite okay. I mean, in the sense that the way you talk to the patient is good. I mean, the way you address, I like your soft skill and also the way your communication. Definitely no issue. But your issue is the time problem because you don't have much time to, try to walk up completely and also ask again if any issue because it's quite tight. I realize that
Right.
initially when you are trying to explain, you seem very protective of the GP and you try to justify a few times and try to, mentioning on the same point again and again because you don't want to
Right.
speculate, you cannot comment. But basically, essentially, it means the same thing. In which, I mean, the first 2 to 3 minutes may be a waste of time because then you cannot come out from that question that the patient is keep on pressing on you. It's quite a difficult scenario. I also when I want to become this surrogate also I feel very suffering. Okay. Because I need to be very angry, I need to be, very, very anger kind of, very unhappy kind of surrogate. Lah. But there's always an approach to this kind of scenario. What do you think the theme for this kind of scenario will be?
I think in this case, we'll probably be exploring medical malpractice, or rather, like a patient who wants to pursue medical malpractice. Would that be
So
right?
so usually we don't mention about malpractice, we don't mention about anything about legal issues at all. So this is kind of like a scenario of complaint, right? Any form of complaint. But this is just a scenario of complaint, okay? And the complaint is because of the delay in diagnosis. Okay. So that was the theme for this scenario. Lah. A lot of people, I mean a lot of scenario can have a lot of complaints. Sometimes it's complaint because of mismedication, complaint maybe because of giving wrong medication in a wrong dose, and that happened in the ward. For that reason, you need to do an incident reporting. But this kind of complaint outside of hospital towards the GP, which is not under your territory, and how do you go about it? Generally, the approach is almost the same, but you need to modify a bit. So I will talk about approach now. So basically, yes, you have mentioned very well. I mean, you start off very good. You also address the emotion. You ask the patient how he feels, and you also feel apologetic as well. You say that I can see that there's a lot that you have gone through, but you need to highlight the fact that I think you need to put a firm stand that to begin with you cannot comment. I mean, you really cannot comment because uh, different people have different practice, and at this point of time, it's difficult for me to comment, and therefore, it's also unfair for me to comment. You can mention like that, and yes, you have very point out, but that's after you going about 2 to 3 minutes. Only then you realize that okay, sometimes the GP said the headache can be quite common, may not be typical or straightforward. Yeah, you finally think about a way through about this. Yeah, but you must mention this upfront so that you don't waste much time because you know that this is something that beyond your control and you cannot comment. Okay,
Yeah.
so you must as well say it upfront that unfortunately I cannot comment, and however sometimes the symptom may not be typical or straightforward, and therefore it's difficult for me to tell you. Okay, but I really understand and aware of your unhappiness about the delay, and I believe that the best person to actually justify is your GP. And however, I can always help to raise an incident reporting. I can also help to engage in the hospital legal team and to investigate with this issue. So what they're going to do is they will usually interview the GP, your GP, and they will come out to what are the conclusion and what are the things that we can improve. But generally, it's difficult for me to comment whether there's any delay in diagnosis. But you need to shift this kind of scenario, regardless how stubborn the patient is, you need to shift the focus from delay in diagnosis from complaint towards the patient care, in which you need to highlight the fact that the patient will continue to receive the most appropriate care, in which you also rightly mentioned this is something is benign. It has been moved completely. There's no risk to, for it to become cancerous or spread to other parts of the body. And you are definitely, and what is the definition of continue to receive the most appropriate care is to mention about surveillance and also the follow-up. You must mention about that, because I think because you're stuck in the first few minutes. That's why towards the end you didn't have much time to really talk about that. But that's the main goal. Your main goal is to highlight the idea that currently definitely he have full rights to complain, but it's very important for us to to make sure that your health is our first priority, and therefore we need to you can still complain, but you will still receive the most appropriate care. We'll still follow you up. We may need to do a CT scan on and off few years later to really monitor whether there's any risk or any issue with your brain. You can mention something like that. Okay. And and also the education about the symptom as well. If the patient have any headache, if the patient have any, because the patient post-op, right, just have an operation. So it's also important to watch out for risk of infection post-operation, post-operatively. So must mention that if you have any risk of like vomiting, headache, fever, then you have to come to our hospital early so that we are aware and we will work out later on if any issue. So that's the goal. And yes, you although it's 10 minutes, very tight, but you are very good. You manage to explore the social issue. So most of the time, this kind of difficult patient, for some reason they are being difficult, but usually they will have some issue. They will have some issue in terms of financially, in terms of socially, that you need to tackle them to tune them down, so that you have more time to to settle your main dish. So social issue is something don't forget in this scenario in which you have mentioned, which is good. Concern, I managed to ask you most of the concern. All concern I managed to ask. The only thing left is the summary and also the management that you didn't manage to talk about. When you look at the scenario is more to express to address the emotion as well as the concern. But part of the concern is actually, part of the concern is also actually to shift the focus from the complaint. Yes, he can complain, he can pursue, we can engage the hospital legal team to help on this. But generally, we cannot comment. And definitely, I cannot help you to sign the letter to complain, because generally it's not the policy. The policy is we will let you engage with the legal team and they will assist you further on that. Okay? You should mention something like that, huh? But I think you are quite okay. It's just that the initial part you are a bit undecided which direction you are going. Are you going to be 100% protective of the GP, or you're going to 50-50 in which you cannot commit, you cannot say anything, or you're going towards no, maybe there is some form of delay. So you are a bit stuck in the initial part. So when you prepare this kind of scenario, you need to commit yourself. You need to tell yourself 5 minutes outside. Okay, what is my approach? What am I going to tell that anticipating angry kind of surrogate? Because if you're undecided, then definitely you're going to spend some time to negotiate about it. But generally, I think your communication skill is good. I have no issue, really good. Just that the initial part that is spent for the undecided path may actually compromise the discussion on the management and the summary lah. That's the only concern. But sometimes I think based on your performance now, even I think in UK or even in the more good examiner, they may also give full marks already, because they like to hear this kind of concept of we don't blame anyone and we don't assume, and like I say, speculate is like assume, right? And we don't really find fault. The main idea is try to try to find out what are the things that we can improve in our system, and as well as the healthcare. So that will be it. Any question from you?
Well, I think probably encountered the same problem with this as I did in my previous session, which is that I'm not very economical with my time. I think, like what you mentioned, spend a bit about 2 minutes to 3 minutes or so going around the same issue over and over again. In this case, though, would it be fair if, let's say, I were to approach this again and I straight away just come in and say, can't say anything about the GP, I can't say anything about their management. If we can only, then I'll tell a bit about what we've done and doing the surgery and everything, but I'll just say that we'll just refer to the legal team if we want to pursue action, but we cannot sign off on anything that didn't happen in our practice. Would that
You
be
can
a
do that.
fair strategy?
Yeah,
Mhm.
I mean, eventually this is the strategy that you should go. But to address the fact that you cannot comment, I mean, you have to prepare that the angry surrogate may be more angry. What? You
Right.
cannot comment? What do you mean about that? Blah, blah, blah. So you have to
Mhm.
prepare that to explain why you cannot commit and why you cannot comment. So you can either do it two ways. You can mention that your presentation, I mean, sometimes headache can be quite common. You can mention that first to kind of like, let the patient understand a bit on the information. Only then you say, for that reason, I cannot comment, unfortunately, about any delay. I believe that your GP is actually at his best interest, but sometimes the delay may occur. But but for your case, unfortunately, for your case, that this kind of delay actually did not actually cause much harm, and the brain tumor has been removed completely. And however, if you are unhappy with these regards, we can always engage you with the legal team, and we see how we can do about it. But generally, my idea to you is, you have right to complain, but I also hope you understand that you will continue to respect your GP and also believe in our management, as you are our first priority in the sense of management, and we hope to see you and make sure that you are well. You can say something like that lah. I mean, there's no right or wrong, but it's either you want to straight away mention you cannot comment to begin with, or you just give some explanation, one, two, three, then only you say cannot comment. But generally, you should mention that you cannot comment.
All right. Okay.
Mm.
We'll do
Okay.
so. I think I'll stick.
Okay. All right.
Thank you.
So thank you. So next patient pula. Next candidate will be Yi Hong. Yi Hong, are you there?
Yep.
Yeah. Okay. So I will give you 5 minutes as well. You're ready, right?
Yep.
Okay. So your time start now.
All right.
You can see that my scenario is getting longer and longer. Everyone will feel very anxious. But that's exactly what happened during the real exam. You should expect the com skill scenario outside will be long. So you need to be fast to know. You should look at the task first and then you read the scenario properly. Okay, time's up. Dr. Lee, this is the patient, Mr. Marcus.
All right. Hi, good evening. May I confirm that this is Mr. Marcus, 30 years old?
Yeah, I'm Marcus.
Okay, Mr. Marcus, I'm Dr. Lee here, one of the medical officer in the chest clinic. So today I'll be discussing with you about your condition. Will that be all right?
Yeah.
Okay, Mr. Marcus, it actually come to my attention that you was actually having diagnosed to have this condition called tuberculosis, pulmonary tuberculosis 2 months ago. Are you aware of your this condition, about this condition?
Yeah.
All right. So the reason that I'm actually seeing you today is because of I actually received a notification from my TB health visitor that actually you were actually only taking the medication from the first day of treatments 2 months ago. So subsequently, you actually not was not on any medication. May I know why do you stop taking the medication?
Oh, doctor, why are you accusing me of not taking my tablets? Do you have any proof?
All right. So, Mr. Marcus, I'm so sorry. I'm actually not accusing you. Just that because usually for this TB medication, we will need you to be frequently and to go to the clinic for us to make sure that you actually take the medication and also prescription properly because TB is actually a treatable disease, and if you are not compliant or if the patient is not compliant to the treatment, it can actually lead to adverse and also serious complication. That's why we are actually very concerned. Yeah.
Mm,
Okay.
yeah. Why are you so suddenly concerned about me? I have spent my entire time alone and I know what's the best for me.
All right. I'm so sorry to hear that. So let's see how we can help you. So first of all, may I just confirm with you that actually exactly how long you actually took the medication for the anti-TB, for the
Yeah,
TB medication?
I only took for 2 weeks.
All right. And why is it so?
Yeah, doctor, I'm very tired. I always forget. And because I don't have much money, I'm staying alone. Financially, just supported by myself. I have to work a few jobs. Part of it include the nightclub. So I'm the bartender. So I usually work from 12, until the 7 o'clock in the next morning. I need to keep the shop clean. Then after that, occasionally I will drink as well. I will drink a bit of alcohol and I may collapse. I will just sleep until the next morning. And then maybe I will go if in the afternoon I have to go to do some errands or even find some part-time job as well. So I don't have time for all this. Medication is not something that I want to take. I don't think I can commit with this.
All right. Okay. So let's see how we can help you with all the issue. So first of all, for as I mentioned just now, this tuberculosis is actually a curable disease. So if you are actually compliant to the medication, in which most of the patient will actually take 6 months of medication, and if you are compliant to the medication, it can be totally curable. However, if you are not compliant with medication, and also if you stop the treatment abruptly, it can actually cause what we call as resistance. And when we have a very bad TB, tuberculosis, it can actually be life-threatening, and the bacteria can actually spread to the whole body and all parts of the organ, and you can actually cause it can be actually fatal. So therefore, it's very important for you to be compliant and for patient on TB medication to complete the medication as per prescribed by the doctor. So
I
yeah.
mean, I mean, how do I going to comply on this? Do you have any ways to help me with this?
All right. So number one, first of all, we can actually refer you to the social worker. Number one, for your job, because I think since you mentioned that you actually work multiple jobs and also have difficult to make ends meet, so we will actually help with that. And working in a nightclub probably will not benefit. And about alcohol, I will strongly recommend you to actually stop alcohol intake because it can actually worsen the condition. So I understand that it is very difficult for a patient to suddenly stop the alcohol abruptly. So therefore, we can actually ask our help from our colleague to see any medication, and they will actually interview you first, and we can actually refer you to the addiction clinic to stop the alcohol
Doctor,
intake.
why do I need to stop alcohol? Can I just cut down?
Okay, so the reason to stop the alcohol is that alcohol, number one, is not good for health for all sorts of medical reason, and number two, as you mentioned just now, you actually frequently get drunk from alcohol. So when you get drunk, you forgot to take your medication, and also when you get drunk, actually sometimes you can cause some that your immunity is actually can be lower, and it's easier for you to get what we call as a lung infection when you are actually drunk, which is without you knowing. So we can actually make your condition even worse.
Mm.
Okay.
How about smoking, doctor? I also
Okay.
smoking. Do I need to stop as well?
Yes, for your smoking, 40 cigarettes is a lot, and technically you need to stop smoking because it can actually worsen your TB condition as well. So how we can do that is that there are actually a lot of ways of replacing the cigarettes. For example, I can refer you to the smoking cessation clinic. We have other method, for example, nicotine patch or even nicotine gums to actually help you in abstinence of cigarettes as well. So that two part, I think we can have a lot of different of my colleague to actually assist you in that. Will that be all right?
Yeah, doctor. Even if I have a healthy lifestyle, but I
Yeah.
still got no money. I still need to work.
Okay. For that part, actually, I can actually refer you to the occupational health, so and also social health worker to see whether we can actually assist you in any financial uh, in any financial, and also we can find you a new job, because I also got to know that you actually live in a hostel for the homeless. So it is very usually when you are exposed to the homeless as well, the risk of transmitting and getting other diseases is very high. So therefore, technically, you should be staying in a more, I would say, hygienic places to prevent the spreading of the disease and also getting other disease as well.
I see.
Okay.
Okay.
So as for the tuberculosis part, actually, you have to be started back on the medication, which is about, as I mentioned, 6 months. So from the notes also, I understand that you actually came from a not so happy family background. May I ask, do you feel very sad about it?
No, I've get over all this thing. I decided that I should be alone, and I need to fight with myself to survive. I need to earn money. I need to, you know, do a proper things, proper jobs. Only then I can survive in the society.
Okay, I see
Two
that you
minutes
have
left.
very good positivity. So, may I know what will be your other concerns?
Yeah, my concern now is, according to what your health advisor told me in the past,
Mm.
I need to get admitted, but I don't want to get admitted, doctor.
Okay, one of the reason for us to one of the option is actually to get you admitted is number one, we can actually properly monitor your once we restarted the anti-TB, the TB medication, and also we can monitor your blood count and also monitor any adverse effect. Then at the same time, when you are in the hospital, we can actually the approach and also the support from the support group from for smoking cessation and also addiction will be much better compared to when you are not being admitted. So that will be one of the options that we actually hope that you can accept to actually admit you to the hospital so that we can monitor you from time to time and also provide you with other support. And when you are actually admitted, you don't need to be worried about your home, and also you don't need to be worried about your accommodation or
Yeah, but doctor, if I admitted, I got no money. I cannot earn. I cannot work. So
okay.
I really don't want to be admitted. Is there any other choice?
So the best option, number one, of course, is actually to be admitted. However, if you are not keen to be admitted, usually what we can do is that if you can be promised that you actually will take the medication every day, there is actually this program called Direct Observe dots, what we call as observe, for you to take the medication. So if you can provide the evidence that actually you are taking the medication, TB medication every day, we can actually allow you to send the video to the TB Health at visitor, in which you can be actually monitored not so frequently and also not being admitted. However, if you actually
Okay, thank you, Dr. Lee. Time's up. Thank you. Yeah. So how do you feel about this?
not enough time,
Not enough time, right? It's the difficult scenario, right?
it's many things to
Many
discuss.
things to discuss at the same time, a lot of issue. So you really need to plan. This kind of scenario, I agree, it's not easy. But we look back at the task. What is the task ask you to do is to explain the issue of non-compliant, in which you explain if not taking anti-TB, then the reinfection, the infectious, and then the dissemination as well as the resistant, right?
Yeah.
So, and negotiating ways to improve is compliance, which is good. You talk about try to get try to avoid getting drunk, practice healthy lifestyle, and then isolation as well, referral to the welfare as well as the social is a welfare law, and the occupational health if needed. And but the problem with this is actually what are you lacking is actually the concern, which is part of the concern is he refused to get admitted.
Admission.
So you need to give some time for the dots part because you managed to explain about dots, but you didn't manage to complete the discussion on the dots, and you didn't manage to ask whether patient is it okay, agreeable for this, and then followed by a summary lah. But based on what you say, actually, yeah, it's difficult. The reason why I keep on asking you, do I need to cut down my alcohol and not to stop or stop smoking? Another reason of not practicing a healthy lifestyle can worsen the lung condition is actually the potential interaction with the anti-TB.
Yeah.
So this is also one of the things that I learned since I'm in respi. So I got a patient, very difficult patient in psychiatry ward, came in and PTB and then disseminated to the spine. So also a very heavy drinker and also an active smoker. So and then this time came in alcohol withdrawal. So the psychiatrist referred me to kind of like restart back the anti-TB, in which the patient stopped for maybe about 2 to 3 days before admission. And patient was in withdrawal, but getting better with the liver function also getting better. So that was the discussion. The question asked by my consultant was, will you start the anti-TB in the ward? And my answer is naively, I mentioned yes. I said, yeah, I think need to start. Since patient got transaminitis, maybe we had to bridge with the SCL regime first, and we need to make sure that there's no discontinuity in terms of the anti-TB, in which he's already on maintenance, not intensive. So just sidetrack a bit of this question. So my consultant, when listen to my answer is, but I will disagree with you. And I immediately got shocked when my consultant tell me like this. But he said a lot of things need to be justified. We need to look things at the whole picture. So sometimes we know that this difficult patient with TB, TB itself is a difficult diagnosis, require a long duration of treatment. We need to really decide whether worth or not to continue the anti-TB, to complete the course, and to help the patient to complete the course if it's difficult. So the main idea is for that patient, he really need to stop smoking, he really need to stop drinking alcohol. And because he's on maintenance and the last x-ray got no new cavitation, and the last CT scan 3 months back was like no active cavitation as well, no necrosis from that we can see from the HRCT, and he's already on maintenance. Actually, doesn't need bridging with the SCL. SCL is only bridged during the intensive phase. This is just something that I learned. And I realized that based on the discussion with my consultant, I realized that sometimes we always focusing on treating the disease, starting the medication, continuing the medication, but we most often we forgot that patient got some other issue need to address as well, which may also affect the compliance as well as the efficacy of the medication. For this condition, for this scenario, to improve his compliance, yes, you can, and to improve his compliance is not just about you haven't addressed the issue of he being forgetful and cannot remember when to take. So I would advise that the simple way is to set a reminder alarm, just a simple alarm, reminder or alarm to make sure that you remember to eat. And then you must make sure that he is highly motivated to do so as well. So yes, you try to motivate him. I think I can see that's a good, it's a good point. But you need to give him some maybe some idea on how to improve the compliance lah. Basically, what you did was to improve his lifestyle in general, but not to improve his compliance. You hope that by improving his lifestyle, he will become more sober. He will live a more healthy lifestyle. Therefore, he will be more compliant, but not necessarily, right? So that's why you need to kind of like suggest some ways to do. To deal with the non-compliant issue lah. And the possible hidden agenda in this scenario is also to ask him to stop smoking as well as alcohol, because the reason is it may make the duration, although the duration may be 6 months adequate later, but it may make the medication less effective, because we are not sure how effective will the medication be despite taking at the same duration. So you must encourage the patient to really stop. If really cannot stop, you want to drink, try to avoid as well. And you can refer to smoking cessation clinic or the addiction thing. Yes, no problem. And you just tell the patient that for at least for this moment, because it's important to complete the treatment so that your lung condition will get better and will not actually attack again this bug. So it's important to highlight on that fact as well. Okay. Otherwise, I think you did quite well. Although the scenario is difficult, but you managed to discuss most of the point. Okay. And the dog's part lah. Actually, other than just take video and then show the dog's nurse, not sure about Malaysia, in which I think we hardly do home visiting. But in UK, actually they did do some home visiting dogs lah, portable like ambulatory dogs, but they cannot do it like every day. They usually do like 2 to 3 times per week lah, for those very difficult patients. But this is something that you can also explore as well. You can tell them that dogs, if you have no one that actually available to monitor you, you can always refer you to this service called DOTS, direct observatory therapy, and so that someone can actually try to motivate as well as encourage and make sure that you are able to take the medication timely. You can just mention like that. There's some options available. Sometimes you may need to go to the health clinic to show your medication pills and also your book, or sometimes they can come over for visiting, but this generally depends on their decision lah. You can just mention in brief lah, no need to mention in details. Okay. Any question?
No.
No, right? Difficult lah.
Can I ask questions?
Sorry.
Hello?
Mhm.
Hello?
Sorry, what was your question?
Yeah, if let's say we can offer okay, if let's say patient can stay in the hospital, we can offer, like, he's a homeless, right? We can offer him that we can provide food, or we can give some counseling help. Is it possible?
Yeah, definitely. Definitely. But we at the same time we also should remind the fact that we admit the patient not because we want to provide nursing care lah, because the hospital is not a nursing home.
Because we wanted to, like, win-win situation. We want him to
Yeah,
compliance.
correct.
At the same time, we want him to basically, because he's homeless, right? His concern is because he have financial issues. At the same time, he got a lot of social issues that we need to tackle as well. Because once his social issues have been settled, then he can comply to our medication, right?
Yep.
So probably then we can offer like a counseling help or any social welfare help, so that actually he can improve in terms of financial, and also
Yep.
can actually help in terms of social issues as well. Is it possible?
Definitely. That will be our first line. Okay, that'll be our first line. But the scenario in this scenario is set such a way that regardless how you counsel, he refused, because the scenario outside also mentions strongly refused lah. I mean, we
Yeah.
can always mention about that. But when he strongly refuse and you are stuck, you know that this is not going to work, and therefore you need to really explore the alternative lah. Because I think the marks the clinical judgment point will comes not at forcing the patient to admit, but instead the alternative lah. You need to focus, because our time are very limited, 10 minutes. You really need to prioritize which one is the one that you really need to spend a bit more time. Okay.
Okay, that means we can give a trial first. Then after that, if let's say still adamant, then
You
we can
should
just
ask the
focus
patient,
on.
should ask the patient
Okay.
whether he's agreeable or not. How about
Okay.
how about we considering the idea of admission at this point of
Okay.
time? If he say no, then it's okay lah. No need to force already. You
Okay,
can just mention
okay.
there's other options, So
Okay.
this is just some approach lah, huh? So
Hmm.
yes, our concern is informed by health advisors not taking the medication. Do you have any issue with taking them? And then show some empathy. And then sometimes you need to know what's the reason of non-compliance. Whether is it because forgetful in his case, busy in work also his case, unpleasant taste also something we need to ask, because sometimes patient may not tell you. You just say don't like the medication, and then or sometimes simply just because they think the medication have no benefit. So for that reason, we need to explore. And the understanding part, yes, and the complication is basically these four things in which I think Yihong described already. Risk of spreading to other organs, risk of become infectious, risk of reactivation later, and then risk of resistant. But we need to tell these four terms in a non-medical jargon way. Okay. So the management to improve the compliance can be a few. We know that accurate 2 is already a combination pill, not a separate. So just mention that actually this medication contains a few medication, but this is a combination pill. It's meant to actually improve your compliance, easy for you to take just once a day, okay, together with the vitamin B supplement. And you can set your alarm to remind you, even if at work, you can bring some spare medication in your bag. And finally, you can also refer to docs. They can consider some home visiting service or some health clinic service as well. And then also in terms of the anti-TB, but if he's worried, if let's say he's worried because of some side effect, then you can mention that we also will schedule some clinic appointments and then to take some bloods to monitor you if you are worried. For isolation part, you will suggest, yes, like what Padmani say, suggest for admission, because actually he's staying in a homeless hostel. A lot of people, they can get infect each other. So, but the key idea is try to counsel him to stay away from the colleagues or friends until the result is negative and the treatment is completed. Even after completed, should not contact with those that potentially have TB as well. And then at this point of time, advise not to work at the public area because he's actually working as a bartender, right? It's still considered as a public area. So consider at this point of time referral to the occupational health, and financially, he definitely will need some financial aids. So that is also important for the welfare to help in. Social part, I think you discussed all. And then you also can consider just like just like HIV, right? HIV, we always have an ID counselor, right? Most of the time when the patient newly diagnosed. For difficult TB patient, sometimes difficult patients, you can also refer to a counselor. They will try to talk to the patient better than us, right? I mean, we just 10 minutes showmanship in the exam, but we can always refer them because this is something that is additional that we can offer, in which a lot of things we may not able to address, a lot of issue. You can see if you really time is tight in this scenario, if you really encounter something similar, you are very short of time, you still have a lot of ideas to explain, right? You can just tell the patient that I believe this session there's a lot for us to go through. I can see that you are quite overwhelmed. It's always good for us to arrange another session with you, and I can also refer to counselor to talk to you in detail about it. What do you feel? Just mention like that to actually show that you are aware that you actually have more things to actually discuss, but you don't have enough time already. So what I'm going to do is, what is the follow-up plan? What is the next plan? Instead of just letting the time's up, then you suddenly stop. It's not that good. So you know that your time is almost up already, right? Even if you cannot able to complete a certain point, you will just do a very quick short closure is also possible. So what we have talked you so far is I will advise ways to improve our compliance. If you have any issue, I can also inform you to the refer you to the social group counselor and also hospital contact if you're unwell. Is it okay? Okay, all right, thank you. Okay, that's all. Maybe you give some 10. Usually the closure 10 seconds is more than enough. But the idea is try not to stop the conversation abruptly. But there's no right or wrong. The examiner will not penalize us if we don't have enough time to complete everything. Okay, but this is a difficult scenario because this scenario deal with a scenario of non-compliance to treatment, which is the anti-TB. At the same time, also got multiple social issues, and you need to suggest how to improve the compliance. So you need to answer the question of how to improve the compliance in the task, and therefore this situation is quite tough. So I received a question. Yeah, Public Health Act and the Detention Act, right? So there is something called as admission under common law, or so-called admission under Public Health Act. Yeah, it's possible to do that. But the problem is that generally we try not to threaten the patient because this is something that patient have consent. I mean, patient have full capacity. Patient can understand. Our role is mainly to facilitate. And yes, we may need to. We if we cannot convince the patient to admit, if last resort you want to threaten the patient with the public safety or public health act, it is possible, but usually I will not go this way lah. What I feel is better is if you able to propose a way that like what Yihong mentioned, we will provide we refer to welfare, we see how we can arrange, whether we can arrange a single room for you, a short stay in a place that you will not have risk to contact the TB for others, as well as transmitting this condition to others as well. So in terms of isolation, not really an issue if you can find a place to isolate, right? So but you don't need to threaten the patient, right? Unless the scenario really asks you to do so, like, but I don't think that will be it. I know that that is written in the notes as well as in riders, also in a lot of other books as well. But generally from my experience, while I prepare for the exam, even though it's written in the book, but I don't see anyone mention it at all in real exam or in the past exam. Because I think to examiner this may be sound threatening. I know in real life we tend to do that lah, huh? But in a com skill actually station, the skill they tested us is not about threatening the patient, but is to let the patient understand, negotiate with the patient, and come up with a plan that both of you can agree. I think that would be the main idea that examiner want to see lah. It's not to kind of like to actually kind of like convey the idea of forcing the patient or threatening the patient under certain act, unless this is psychiatric patient, for example, suicidal, PCM injection, you think the patient not safe for discharge, patient is suicidal, patient is very depressed, then under mental health act, yes, but that is also not for admission, it's for mental health act, just for the mental health team to assess. And if the mental health team thinks that it's safe, the patient doesn't necessarily need to be admitted. So again, back to the point that we are not forcing the patient, we are just making sure that our patient is safe lah. So that's the idea. So do we need to inform his boss regarding smear positive result, notifiable disease, and also causing third party harm? Very good question. Oh, tonight I got very good question. So informing patient about smear positive, first thing is we don't know whether it's a smear positive. So if you look back at the stem, okay, the stem mentioned that symptomatic, okay, the stem mentioned that actually same as baseline, but the symptom is still there and not gaining any weight. But the stem didn't mention anything about smear positive, whether patient is infectious. And we are concerned because we cannot exclude the fact that patient may be still infectious, right? But we are not sure whether patient is smear positive or negative. So for this reason, we can always mention that we can always notify and for contact tracing and inform the employers, everything. But we don't necessarily need to mention that in detail. We can just mention that if your condition turned out to be infectious, we may need to inform to the health inspector, or you can mention the public health team, and to see whether they want to to screen for TB in those you are contact with, for two reasons. For the reason being, those that you contact with, they may spread the infection to you later on, or for second reason being, you may potentially infectious to others. But generally, this is not the point of discussion, because I think 10 minutes is very tight. So for 10 minutes, to me, it's still back to the task. What is the task? The task to address the issue of non-compliance and then negotiate the ways as well as the concern. So by doing all that, it's already 10 minutes. You don't really have that. Unless patient specifically, if the examiner decided to calibrate to kind of like want to test your idea on disease notification, they will really set a question for a surrogate to ask. So if they didn't ask part of their concern, you don't need to answer. Meaning to say you don't need to automatically talk about disease notification. However, if this is a newly diagnosed TB, smear positive PTB, right? Newly diagnosed, this is like 2 months ago, now we don't know, right? But if this is a newly diagnosed PTB, then yes, we need to mention about disease notification automatically, okay? And isolation. We need to discuss about that. But For this kind of patient, non-TB on treatment, not really compliance, neither here nor there. Generally, we don't deviate our focus to discuss about them, those kind of issues, because those are the minor issues. You need to focus on the main dish, which is the non-compliance. Okay, so you need to focus in order to get the clinical judgment marks well. So that will be the main idea lah, huh? But yes, if they ask, definitely they need to screen lah, huh? If it's turned out to be infectious. So last candidate will be Dr. Chia. Are you there?
Hi, I'm here.
Yeah, Dr. Chia. So I will give you 5 minutes. This will be our last scenario. Now is what's the time now? Almost 10:30 already, right? So we will give 5 minutes and then we will start. You are ready, right?
Yeah.
Okay. Longer and longer, like I say, the scenario. So yeah, this is the scenario. You can start now. Sorry, not this scenario.
Not, not, not please. No. Mm. Oh, sorry.
Okay, time's up. Dr. Chia, are you ready?
Yeah.
So this is Miss Catherine. Please start.
Okay. Hi, good afternoon. Hi, good afternoon, Miss Catherine. I'm Dr. Chia, one of the doctors in this medical ward. Um, just to confirm, are you Mrs. Carroll's daughter?
Yeah.
Okay, I believe you're here to speak to me regarding your mother's condition.
Mm.
Before we start this consultation, would you like to have anyone else of the family to join us?
No.
All right. So, just to make sure that we are on the same channel, would you mind telling me that how much have you understand your mother's recent conditions?
Yeah, so my mother actually was admitted from home because of some vomiting. And then they did a scan, they say it's normal. So but the main issue is we realize is that she's not really tolerating feeding, and she started to feel like not wanting to eat anything lah. I mean, we try to feed her, we have issue, and then sometimes she takes small amount, sometimes she choke, and then we feel it's a bit unstressed. I mean, it's not safe to swallow, and then we really feel worried, and we don't know what is the next step, doctor.
All right. So I think your understanding regarding your mother's condition is quite clear. And would you mind if I add on a few more details regarding her?
Sure.
Yeah. All right. Before that, were you aware that she was diagnosed with a condition of a memory problem?
Yeah, dementia, right?
Yes, correct. So, how much do you know about her problem regarding her dementia?
I was told that, I mean, when she has dementia was like 6 years ago, and then she was started some medication to improve her memory. But I mean, subsequently the medication doesn't work much, so that's all. We stopped the medication by ourselves lah. And then she also not really want to take a lot of medication. So since then we also feel that her dementia is like gradually becoming worse. And previously she still can walk, she doesn't need much support. But now, recently, in the recent months, she is not walking at all. She's just sitting, and then she did not even communicate with us. So we know that maybe the dementia has been really bad now.
Yeah, I can see that you are really worried of her condition at the moment. And yes, you are correct. Her dementia actually progresses, and now she come to a stage that the medication actually won't really work on her because this disease has already been so advanced. And the problem on the swallowing you were mentioning was also part of the progression of this dementia actually.
Hmm.
Yeah. So your mother has been seen by our consultants, and we come to a conclusion that for your mother, Mrs. Carroll, we wouldn't pursue any further aggressive therapy for her.
Oh, what you mean by aggressive therapy, doctor?
Yeah. So in case that she requires some investigations which involve a lot of needle needle poking or chest compression as well as putting a tube into her mouth, and these all are invasive and aggressive medical therapy.
You
And
mean you are not going to take any bloods for her anymore?
at the moment, I think we will take the blood whenever is or we think that is indicated.
Mm-hmm.
Yeah, but on the other hand, as what I've described to you just now, for all the aggressive therapy, we wouldn't actually pursue for her further.
Doctor, what is the reason she cannot eat or drink?
All right. So I tried to explain earlier. Is the problem that arise from her is actually the progression of her dementia. Dementia is actually part of the brain is actually regressing. They are not functioning as of she was young last time. So part of the brain is controlling the our appetite and our swallowing as well. So because of that part of the brain most likely has regressed and it become not really fully function. That's why Mrs. Carroll is not interested in food and she's not taking food and swallowing it appropriate also. These are all
Mm.
arise from the dementia actually.
Doctor, how about putting in a rice tube for her? Then she can at least take some food, you know. Her stomach can still digest, and then she can still get some nutrition.
I believe that your this concern is very valid. We will try to discuss again with our consultant. To maintain her nutrition is also important part of our management now. As what we are heading at the what we are heading towards now is actually to keep your mother as comfortable as possible.
Mm-hmm. And
Yeah.
and how do you do with that?
All right. So as you can see in some of our patients, there's a tube attached to their nose. So the tube actually is introduced through the nose straight directly into the stomach. After that, after confirmation of the placement, we can actually give her the milk formula after consulting with our dietitian as well, so that she can get enough nutrition. And we will also teach you on how to provide this feeding for her.
I see. That would be good,
Yeah.
doctor. That'd be good. How
All
about
right.
how about
So,
considering
okay.
restarting back the medication to improve her memory?
Yeah, the medication we have started about a year ago was actually at the moment might not be really working for her, as her dementia has become so advanced that the medication wouldn't really help in helping her symptoms actually. So our consultant has decided to stop the medication for her.
I see. Oh, then what is the next step?
All right. So at the moment, our aim for to help your mother is to make her to make sure that she's at her most comfortable state. So what we are going to do is as mentioned, we will start feeding for her just to make sure that she got enough nutrition. After this, we also refer her to one of our specialists in handling very elderly patients, and so that we can teach you on how to take care of her at her current state. Does it sound all right to you?
Okay.
Yeah. So I'm so sorry to tell you this, that your mother actually looking at this condition, she may be at her final times already, Mrs. Catherine.
Oh, how long she will live, doctor?
Uh,
We know that at
we
some she may leave us, but how long do you think she will live?
it's quite difficult for us to give a assumption like this, but I would advise that if any of your family members or your siblings would like to see her, they can come over and visit her in the hospital. But regarding how long more she will be with us, we are really difficult to tell to give this assumption actually.
I see.
Yeah.
So
I
can we bring
Yes.
bring her home?
All right. Once we have because her initial problem when she come in here was regarding the vomiting, and once we have established all the fine tuning all the feeding and the other parts of teaching you how to take care of her, how to do some simple physical exercise for her, and probably we can discuss about the discharge during that time when everything is ready. And we also refer you and your mother to the social welfare department, and to let them have a look on how to get some suitable medical equipment prescribed by our occupational therapists and physiotherapists as well. Does it sound all right to you?
But she cannot move already, or what? I mean, what kind of quality of life you want to aim for her?
I believe with the by making sure that she's not in pain, and by helping you and your siblings to actually be with her, to accompany her, I believe this is the most appropriate uh, kind of treatment for her actually, just to keep her as comfortable as possible.
Doctor, how to make sure she's comfortable? Because sometimes she seems like to be in pain. Is there anything you can offer?
Yeah, if we try to refer to our pain service as well, the specialists who are specialized in pain control, we will try to locate where the pain, if she could tell us, and we will prescribe some painkiller accordingly to help her to ease her pain actually.
Okay, doctor. That
Yeah.
sounds all right.
All right. So I have some questions to ask if you don't mind. May I
Mm.
know who is taking care of your mother?
I'm the main one taking care.
I see. Is there anyone helping you in taking
Yeah.
care of your
Time
mother?
time's up. Okay, 10
All right.
minutes. Okay. All right. Thank you. Thank you, Dr.
Thank you.
Chia.
Thank you.
Yeah. How do you find about this scenario?
Actually, I was finding the point. Is this a kind of DNR kind of scenario, or
Mm.
is it the scenario on discussing on further management? But there is no room of discussion because there are actually no management option for the patient as well. So I was looking for the heading actually to approach this case.
So you are actually self-conflicting, right?
Yeah,
Because the scenario clearly written that your consultant say that further intervention is not appropriate and the palliative care is the best approach. So
yeah.
yeah, so the palliative care, full palliation, and this is the advanced dementia that cannot move, cannot eat already. So
Yeah.
what would be your approach if you're going to do this scenario again? What would be your approach?
Actually, actually, I'm thinking whether the rice tube feeding is appropriate in this context or
Yeah,
not. Yeah,
correct. So this is also a very important question that is designed in this scenario to actually assess our understanding on rice tube feeding in a so-called terminally ill patient. Whether there's any role to actually still giving rice tube feeding, you know.
yeah.
So what is your take?
If
Insert or not
if
insert?
this if he is really terminal ill, insertion of rice tube is not appropriate.
Mm-hmm. Do you
Yeah,
think
if
she is terminal ill?
it's quite difficult to make a conclusion like this, but I think from how you prompt me now, I think she is terminal ill.
I won't say terminal ill as a word, but I would say that this is a terminal disease, right? This is
All right.
advanced dementia is a terminal disease. So again, we should not. I mean, in your hospital, do you have a geriatric service or any
Yeah, we
visiting?
do. We
You
do.
you do lah. And what was
Yeah.
your geriatrician practice in a very elderly patient that come in, like for example, pneumonia, and then cannot really saturation much, need oxygen. Will you insert the rice tube routinely?
I think nutrition is kind of their big thing also. They will make sure that patient will get enough nutrition. Yeah,
So again, there's no right or wrong, but it depends on the patient premorbid condition. So there's something as what we call as we always like to use this CFS, clinical fatality scale, right?
yeah.
So if you're going to scale this patient, what is the CFS like?
I
Do you
think it's
know?
almost 7, 8 already
Cannot be
towards
seven,
the
it's
end.
eight. It's eight.
8, yeah,
Seven still can do a bit lah. Still can, you know. I mean it's totally bed bound, but at least still can eat a bit with assistance. But this is eight already. Eight
yeah.
and nine is really death already. Like eight is already moribund. Huh? So if you're able to tell yourself that this is a CFS eight, are you still going to do anything at all? The question is, so this is
I
a very difficult question, right?
mm,
So and in my hospital, our practice is our consultant are very pantang if you insert rice tube in their Jerry patient, even in those very stable one. But we try not to insert lah. But those looking at the outcome, looking at the baseline clinical fatality, if it's very ill already, like we are talking about 7, 8, even 7 also, we will not insert rice tube lah. We will give hydration, we will give drips, but we will not give rice tube feeding because it doesn't serve any purpose anymore. And but having said that, we need to tell the family members so that they understand because they can get very anxious why we are not doing this, why we are not doing that, and you will get a dilemma of aggressive therapy. You mentioned something like including blood taking, right? But again, are you going to take blood for her? Will the blood taking change the management? Let's say require intubation, oxygen level, PO2 is low. You're still not going to do anything more than just comfort care, right?
yeah.
So we have to be very clear when we talk about comfort care, it's a comfort care. It is not supportive care and definitely
Okay.
not something active. Comfort care is something that we really need to make sure that we let it understand what is the role of palliation and what is the definition of palliation. So this, I think, you have a very good attempt in this scenario, but there's the things that you have to probably adjust a bit if you encounter something similar later on. But this scenario, another role is actually to actually explore the palliative care. You have to explain what is palliative care. I noticed that you explain a lot of times comfort care. You mentioned that the main role is to keep her as comfortable as possible for comfort care, but you didn't mention what is mean by comfort care. That's why I asked about pain. But when I ask about pain, I expect you to, tai chi to palliative referral, and then you can get more details. But instead you refer to APS, which is part of the palliative care, but not palliative care per se. So that's why in this scenario, it's important for you to bring in the role of palliative care. Okay. So this kind of scenario can come out in exam with a different forms. For example, the patient have a stroke and it's a very massive stroke. Okay, very, very massive stroke with a midline shift, neurosurge referred. They think it's not a good candidate for surgery, and you know the outcome is very poor and GCS is flat, something like that. And the consultant decided that the management with palliation or comfort care. And then you're talking to the doctor anxiously to explain about the decision as well as the concern. Almost same scenario. Like, I mean, the approach is the same. It's the same team in which you are dealing with a patient with terminal stage of illness, or what we call as terminal stage of life. Huh? So this kind of scenario, how do you approach? So I will go through. So first of all, yes, the good thing is you explain what is advanced dementia. You explore the understanding of the daughter towards the disease, towards the presentation of feeding intolerance as well as dementia, and then you further describe what is dementia. So dementia, you say regression, right? Regress. So regress, it's not a fully medical jargon, but again, it's a very technical term. Not so educated people may not learn about regression. So it's basically mean degeneration, but again, it's a medical jargon, right? So to substitute degeneration, we usually use death and damage of the cell. That will be degeneration. Autoimmune disease, we always have this template, right? In which is a situation in which the immune defense of our body that normally attack the bugs start to attack on your own cells. In this case, attack on blah, blah, blah. So this is the autoimmune, right? But degeneration, we always try to use a simpler term, like it's a progressive damage and death of the brain cell. And the damaged brain cells are difficult to be repaired at her age. In fact, the dead cells are impossible to be recovered. And both of this is actually an irreversible form of injury or insult to her brain. And this will cause her unable to remember, unable to talk, think, move, or even recognize familiar people around her. The outlook, unfortunately, at this stage is very poor because her condition is not reversible. The management for her in this condition, unfortunately, there's no effective treatment to help the brain cell to survive or even resume the function. And therefore, my consultant have decided that the way forward is to referral to our palliative care specialist to make her comfortable and pain-free. Have you heard about this palliative service before? Then only you start to explore the idea. So they may be a bit denial, they may be angry, they may be sad. Just give some time for the emotion. But you need to explore about the advanced directive and lasting power attorney. So, you don't need to explore in detail, just 2 questions. You can ask the patient, doctor, that have she ever expressed her wish that, if one day she's unwell, she cannot make decision, what would be her wish? Okay. If not, then have any one of you discussed or even her appoint anyone to be the decision maker in this condition? Okay. Usually no lah. Huh? And then only then you actually tell about what's palliative care. You say this is a form of treatment that does not target the disease itself, but it rather actually aims to keep patient as comfortable as possible by managing pain and any distressing symptom, not only pain. And this involves a multidisciplinary team consisting of pain doctor, palliative doctor, nurse, psychotherapist, sometimes even involve all the the religion workers as well. So it's a form of multidisciplinary care. So you need to tell that it's not to say that we're not doing anything, but our role, like you say, is to keep her comfort. Okay, so that's why the referral to palliative care would be good for her. And here comes the discussion of the rice tube. So if you look through the if you look to the literature as well as the NICE guideline, right, there's something called as a life-sustaining treatment. So what is this about? I also feel that, I mean, this is what Dr. Hassan taught me previously, but I also feel that it's easy to explain this way for the surrogate to understand, and also for examiner to understand that we are not pushing patient daughter to a certain decision, but we are explaining the condition in a gentle way. So life-sustaining treatment is basically there are many types of treatment to keep people with advanced disease to remain alive. And this will include nutrition, fluids support through the feeding tube, medication, sometimes oxygen support. I'm very sorry to tell you that your mother have a very advanced disease and there's really limited chance for her to recover. Eventually, this is the key word that I feel is useful. Eventually, there may come to the time that there's no prospect in recovery and she could leave us anytime. What do you feel about that? So always check back the understanding of the patient surrogate. Eventually, this form of treatment will not have any benefit, but will prolong the dying process, and this will actually increase the suffering as well as the family member suffering. Our medical teams feels that actually by giving all the fluids and feeding will only prolong the process and will not give any benefit to her. And she may develop complications like infections, clot in the legs, sores, or even aspiration if her bowel doesn't move as good as it should. And this would again further increases her suffering. What do you think about that? Again, check back the understanding. Okay. The the approach for this kind of patient is not to rush and then force them to accept everything, but is to tell them one by one and check their understanding. And only then, if they understand, for this reason, it's better to stop giving her fluids or feeding. I'm sorry to tell you that, but this is really important for people who love her deeply to understand about her current condition. So if let's say surrogate refuse or really cannot accept this kind of management, so you can always say that I will also arrange a meeting, separate meeting after this to my senior colleague or consultant to discuss further on this issue. Okay, so it's actually important because I realized that a lot of scenarios, something similar, especially discussion on the advanced diseases. Most of the discussion, I realized that is to against right steel insertion, against the supportive kind of therapy, but instead fully palliate the patient. So this is the kind of scenario that you need to consider to do that. If you think that you cannot commit and you feel a bit dangerous to commit, then yes, you can always mention that you will discuss with your consultant and we will discuss it in detail. Okay. And sorry. So in summary, if you got time, you want to provide some leaflet on the end of life care and hospital contact if any inquiries. So in UK, there is something called as what is it called already? I think it's the Maiden's Nurse or sorry, Macmillan Nurse. Okay. In UK, that's called Macmillan Nurse. The palliative nurse that can do home visiting. In Malaysia, we got hospice. We also got something care, I cannot remember. Got a few NGOs but it's also important to mention that there is also some NGOs that we can engage in to provide some care if she's at home later on. So the question of can I bring her home? Definitely yes. If her condition is okay, you all have decided and already know how to take care of her, definitely we can send her home with the idea of knowing that she's reaching the final stage of life. And it's important that at this stage is to keep her comfortable, like you say. And then if any issue, any distress symptoms that you all are worried, you can always come back to us, contact our hospital contact, and also engage in the NGO nurse something like that Any question? Yeah. Hello. Yeah. Can you hear me? Are you still
Yeah,
there?
yeah, I'm still here. Yeah.
Do you have any
Right.
question?
I think I understand already. So whenever this kind of end of life kind of situation, we will just uh comfort care, full comfort care.
You need to really talk
Okay.
about comfort care and you need to define what is comfort care. I mean, in more details. So this is definitely a EOL kind of situation now, end of life care. So but again, I encountered something similar during my real exam, which is also end of life care. The task was to explain about end of life care to the patient and address the concern. And the scenario is super long. If you think my scenario is long, right? The scenario I encounter is really long. Got 3 paragraphs one. The whole paper is full one. So the scenario is saying something like the patient have heart failure, multiple exacerbation. The patient also got CKD approaching end stage but refused dialysis. The patient also got what else? Got stroke before, but otherwise still able to walk a bit. And then the patient also got diabetes, hypertension, all those usual things now. Uncontrolled hypertension, diabetes, oh. And this time actually came in the hospital because of what is the issue? I can't remember. Something like fluid overload or something, but already stabilized. And then your task is to talk to the patient regarding the end of life care, and I mean the end of life plan. Didn't mention about end of life care, and to explore the patient concern. So it's, to me initially I thought it's a simple case, right? But surprisingly, I tell you, this scenario kills me almost totally. I only got 4 marks out of 16 marks for this scenario, in which the total marks for com skill is 16 out of 16, right? And when I request the exam feedback, I want to know what happened, why I suddenly got minus almost all the mark other than the addressing concern as well as the maintaining patient welfare. Really got surprised because they really look at what words we are using. Unfortunately, at one point of time when I counsel the patient, I actually asked patient one by one what did they want. I mean, because the patient refused dialysis, I explained about dialysis and explain whether she wants dialysis and what is the reason she don't want dialysis. And then at one point of time, I still need to counsel her regarding the DNAR part, in which I should ask if her condition deteriorate, do you want us, I mean, essentially we need to commit whether CPI intubation this to the patient. And that time, I think my mistake was I was not giving patient any chance. I think that was the feedback, in which I just mentioned that I feel that based on your condition, chest compression or doing this electrical therapy or even putting in a tube if you have difficulty to breathe may not be a good option for you. If you come in with next time with the same symptom, I would advise not for CPR. I mean, not for chest compression, this and that. And I counsel them regarding I counsel the surrogate regarding the side effect and everything, right? And one of the side effects including you may become because I don't want to use coma that time, in which considered as a medical jargon, right? So you may, I don't know why I even forgotten that I mentioned about this in the real exam, which is really, really pantang. I think that's the reason examiner give me 0 mark for the judgment and everything. Because I mentioned at one point of time there is a risk that you may become instead of saying coma, I mentioned vegetable, that's why it's very pantang. You cannot mention something that you should not mention. And I really didn't realize I mentioned that. And now that I think back, when I got my exam feedback, both examiner, they really they may not able to hear everything, right? But they really listen to that vegetable. So basically they explain to the patient that she will become vegetable if proceed with CPI intubation. No empathy. Wow, that was my comment. That's why I got 0 mark for all the thing. Very personal, right? But again, they are not wrong actually if you think back. Now when I think back is that in that kind of scenario in which patient is stable for discharge but got multiple comorbid, perhaps the ideal way is to explore the option. We don't direct one direction for them, but instead we give them option. We explain to them, okay, actually you need dialysis, but without dialysis, eventually your toxin will be on the body and you will be, you will you will have a lot of symptoms. You may have fluid that accumulate in your lungs and causing a lot of distress. Okay, so all these things you may experience. Okay, but do you agree with the dialysis? Because with dialysis, actually still her condition may not be that bad, So actually we still need to again ask her again options. Okay, no dialysis. Why? if she's afraid and she already says she's elderly, she's old, she don't want to go through all the pain of dialysis, okay, that's fine. Then the second thing, perhaps, if I'm going to do the station again and better is to ask when I ask about chest compression and the intubation, instead of telling her that there's no role to do this thing and that, I should perhaps offer her and tell her about this. So in a critically ill situation, sometimes we need to decide whether we need to do chest compression on you to restart your heart if your heart suddenly stop. What do you think about that? And I realized that frequently and constantly checking the patient understanding is a way forward. It's the idea that the examiner wants to see instead of for us to commit, for us to say that no, there's no law to do this and that. Because if the moment we say that, they will feel like, oh, this one doesn't really discuss with the patient, but should really say like that. So no empathy. Exactly like what I was penalized. That's what I feel. But that was kind of the situation or scenario that I got encounter in which the patient is not actively dying, okay? Not actively dying, at the same time, still can have some mobility, and she still not too bad. I mean, she still can say that uh what she want, what is her wish, and all that. So she still can give her consent. She's still very good in understanding about her condition. Then perhaps is to ask her what is her understanding, and one by one we discuss. That's the end of line kind of discussion. But for this kind of situation, scenario in which she is reaching the terminal stage of life, and you know that there is no outcome, even though if you do anything else, then perhaps you should commit to yourself that this is, and the scenario actually pointed that palliative care, okay, and further everything investigation is not appropriate. So this kind of scenario is already helping you to make a decision that this is for comfort care. So you don't have to be worried like what I will be experiencing, like just give one choice, don't allow patient or family members to choose. You don't have to go through that dilemma, because this scenario is already saying that the patient condition has very poor outcome, and you should not do anything other than comfort care. So this kind of scenario, you should go all the way to the comfort care. Okay. But for my scenario, the experience that I got, yeah, that kind of scenario is a point of negotiation. You should really discuss one by one and see what the patient want. Okay, that would be the ideal lah. Because I got another friend that do something similar like what I mentioned. Just discuss one by one and just let patient talk only. She don't want this, she don't want that, and what's the reason? And then number 2, number 3, number 4, and then she got full marks. Yeah, I was like, okay. Then I really realized that sometimes in exam, in a sensitive situation, you should not say something that is really may irritate the examiner. Like what I did lah. I think I say the vegetable one is something that I should not ever take. Even if I think back, I said, how come I say like that? Crazy one. Because sometimes when you're stressed, you don't, you know that you cannot find a good words for a certain jargon. You may blurt out something that may not mean harm, but to examiner is mean rude or even mean no empathy like that. Okay, so that will be my take now for all the home skill. So again, that's one question.
Jenny, if let's say in your case, you said end of life care, right? So can we offer at the time palliative? But we can say
Yeah,
can we
yeah.
refer
I
to a
mean,
palliative?
the scenario is actually hinting us to refer to palliative like for further discussion.
So that means you need to mention about CPR or
No,
because
we
it is all
we need to
it is
mention. We
all
need
the
to mention.
palliative.
We need to
Oh,
mention.
okay,
End of
okay.
life care doesn't mean that end of life care can mean both way one. It depends on what the patient wants. So unless the patient is already cannot make decision and the prognosis by the primary treating doctor is already poor, and therefore the decision comes from the primary treating doctor, then yes, the decision is made. But let's say the end of life care is something need to be discussed with the patient, him or herself lah. So if the scenario asks you to discuss about sorry, advanced directive or end of life plan, then you should discuss one by one lah. You should talk about
That means
CPR.
we can say uh s- if situations were to be worse, if you come for a second infection or second severe symptoms that
Mm.
requiring certain aggressive in terms of aggressive treatment, then probably we won't be doing such. You will actually will make sure you comfort, and probably the palliative team will explain to you further in the few
Oh,
sections later.
I don't think this is a good way. You
Okay.
should say that. You should ask patient, how will you think about that? What do you want?
Okay.
Instead of you are giving the suggestibility
Options.
like
Okay.
what I did lah. What I did is exactly what you did, what you are
Okay.
mentioning.
Okay.
So I will say no next admission, no for CPR, no for intimation, no for everything, right? I mean,
Okay.
she
Okay.
also agree, right? Everything seems okay, right? But you get 0 mark. That's the problem.
Okay.
So the
Okay.
problem
Okay.
is to if patient have capacity and patient still able to understand and patient is
Mm.
willing to talk about this end of line or advanced diabetic thing, you should ask patient and you should let the patient choose. And we
Okay.
don't discourage, we don't encourage. We just maintain a neutral point.
Okay.
If the patient wants active, let's say patient really want active, don't I mean we don't mean to harm patient. We don't have to challenge the patient as well. We just mention about the disadvantages or CPR, compassion, things like that. And again, ask again what is the understanding.
Because
Then
he
if
got the
she
capacity to actually decide what he wants, isn't it? Is it? That's
yes,
the.
yes, she still
Okay.
have capacity. Then she should
Okay.
decide. She should decide. So
Okay.
that is the
Okay.
problem with me. Lah. I realize that is the scenario. So that's
Okay.
why sometimes
Okay.
the scenario very tricky. You need to read through what is the thing that they want to test. Lah. Okay. So if
Okay.
she has capacity, you ask her understanding. If she refuse, you explain again, like all the disadvantages. If she still refuse, it's okay. Just tell them that it's okay. You can continue to the next point. After you discuss everything, you can tell her that uh I can see that there's a lot going on here. Definitely is not the best time to discuss everything in one go. I can also let you talk to my consultant to discuss further on these issues lah. And then what perhaps one of the thing that if you got time like what I did was because the task is to I mean for her she agreed for palliative referral everything lah. So I did ask her next admission, did she want to come to hospital or she wants to keep at home lah. So this is another point that but it's not important at all lah. Compared to vegetable one vegetable already 0 mark. They don't want to listen to me already. So it's important. You really need to choose your word carefully, and you
Okay.
really need to make sure that uh you give patient options if patient have capacity. Okay, and generally, just for experience sharing, the reason I can pass despite my com skill is like 4 out of 16, right? Actually can be dangerous because the component pass for the communication skill it's just exactly like what I experienced. I got 12 out of 16. The passing is like 11 out of 16, right? I mean the total score everyone will usually pass one, but it's just the component pass. That's why it can be dangerous. Tom skill, we must treat it seriously. We must really know what is the task. Okay. And a lot of people surprisingly can either go two way in real exam. It can either fail the clinical station for short case, or it can either fail the com skill. Or sometimes somewhere in between is the so-called the O series of BCC lah, now the clinical consultation. But I believe that with the longer duration of the clinical consultation, everyone should be able to score quite well because examiner also got 5 minutes to hint you if you miss any sign. Also got 5 minutes to hint you in the history if you miss anything, or even when you mention about the management for clinical judgment. I think there's a lot more opportunity for you to score as compared to the BCC. But for the new format, I think the com skill, because you got two com skill, it's not just one. So again, we hope that all the com skill are straightforward lah, huh? But again, they already expected you to use 5 minutes to prepare, so they can come up with various kind of scenario, be it long, very long-winded paragraph or short paragraph, or sometimes they give you like a 50-50 thing. You don't know whether you want to commit or not. So it's not easy. To me, com skill is not easy because in our setting, first we don't practice com skill in English that much, and second is our culture is also a bit different for UK, and that's why it's a bit difficult for us sometimes to really counsel. It's as opposed to those working in NHS in UK, they doing this routinely. To them, this is like a bonus station, but to us, it's a killer station. So a lot of time, the Asian, including not only including Malaysia, including Singapore, including Thailand, Myanmar, Indonesia, when they take the exam also, com skill is the one that can kill. Okay, I almost got killed. Luckily, I didn't because I scored the rest of the station almost full marks. So you can see that it's very important to aim perfection for all the station. Because we never know. Suddenly you got killed by things that you don't know or things that you done but you didn't realize. Okay, this is just some experience sharing. Okay, so anyone have any question? Terminally ill. I saw one question, but not terminally ill, not dying. So the NG2 is not advisable. So again, this is a win-win situation. Patient is not actively dying, okay? And let's say the outside scenario didn't mention that you need a comfort care, you need to, already decided that this is palliation. So in that condition, then it's a win-win situation. There's no right or wrong, actually. So you can say that if you don't want to commit, yes, what you can do intelligently is you can always consult your consultant, and we will talk about this in detail. However, unfortunately, at this point of time, I would not able to give you any good input. I hope you understand. It's okay. If you don't know, you don't have to commit. It's okay, one. Okay. So this is the difficult scenario, lah. So not that all patient not supposed to be on rice tube if patient is old enough. It's not that way. If patient still have good quality of life, let's say stroke out already, but still able to walk a bit, still able to take care of self a bit, and then there's no no discussion on the direction of care previously, and your consultant, the outside scenario didn't mention anything that you want to palliate the patient or anything, then please don't mention that you don't give the rice tube, which is not fair. Oh. Yeah, the typical question, Ong Ji Sing, right? If patients still have capacity, patients still auto for active research. So usually they won't give this kind of scenario, which is not fair for our candidate, because now we only got 8 minutes. I mean, so-called 8 minutes plus 2 minutes of concern. We only got 10 minutes. It's not fair to give this kind of scenario, but the opposite can be. But generally, if let's say patient fit for consent, the decision making should come from the patient. So this is very straightforward. Decision making should come from the patient. Okay. Decision making only come from our treating doctors is when patient cannot give consent. If patient cannot give consent, then we look at few things. First thing is whether patient have any advance directive. Patient already legally signed a directive that he want this and that. Okay. If not, we look at whether patient got any lasting power attorney. So let's say patient got both. Then which one should follow? If it's different, then you should follow the latest one signed. In which, if patient sign a advance directive before, and then recently got lasting power attorney, then suddenly also sign another advance directive again. So you follow the latest decision given by the patient. Okay, but this decision can be regardless of advance directive or LPA, right? This decision can actually override by the medical doctor decision. Meaning to say that, let's say the patient is terminally ill, got cancer, right? Common scenario, for example, HCC, coming bleed. Do you want to stop, or if let's say this is a bleeding HCC, so the management will be tase. So do you want to tase the patient or don't want to tase the patient? So the scenario will ask you to counsel on tase, right? Meaning the scenario is actually asking you to tase the patient, right? But let's say you got, I mean, when you ask about the advance directive, patient has, and then okay, lasting power attorney got, but they don't want, then what is your role? Your role now is actually to decide whether you should go for it or not, because you know that if you don't go for it, patient will definitely will die. But if patient go for it, patient may survive and may still have some quality of life for a certain limited amount of time. So in this kind of scenario, yes, you should proceed and follow the, let's say patient, let's say the LPA is also the agreeable, then no problem. But let's say it's not agreeable, but patient, but you think that the scenario actually asks to counsel, then you know that the scenario is actually asking you to counsel. So medical decisions still can override the LPA. Okay. So it's a bit confusing because the decision making, who is the most highest authority? Conclusion is the patient. We always need to respect the patient authority. Like what I did, my mistake was I did not explore the patient yes or no. I just give patient yes, no, this. That's why I didn't kind of like address the patient authority. So that's the reason that I did not able to score. Okay. So any other question? If not, we will end our session. Today is a bit late now. Already almost how many hours? 3 hours and 30 minutes. If no question, then we will end our session. I'm just going to go through the question again. Yeah, I think no more question. So everyone can leave the conversation while I will going to stop the recording. Thank you everyone for attending. If any question can still ask in the group. I don't really have time to really provide further com skill session. Perhaps this is the last com skill session already before you all go for exam. For those taking the exam, I hope that you all can learn different variety of the scenario. Okay, and I think I have go through almost all possibility of the team lah. First, to explain a disease, explain a complication of the disease or medication or therapy, and explain about Giovanna Venus also we go through those a bit less practice like drug trial also we go through before, right? So these are all some variation, other possible variation lah. So I hope that you all can benefit. Just for some sharing of knowledge. I may not be 100% correct. Okay. It's always good that if you all can practice with consultant that already passed the MRCP and they are really they know the MRCP style well lah. It's not those that pass MRCP then YOLO already, then they may not know the actual correct thing. The best person to find is those that actually is examiner with the FRCP. If they are the FRCB and they have an examiner, they know what is the scenario one, and it's easier to actually get idea from them. What is the direction in this kind of scenario? What you should do about it. So we always learn, There's no one person that's always right. I may be wrong, okay, but the important thing is actually to know the exam style so that we all can be safely pass the exam border lah. That's the most important thing. Just a safe pass is better than certain heart attack like that. Okay, so I hope everyone enjoy tonight. Okay, bye. You all can leave now because I cannot kick you all out.